Hi guys, welcome back. Welcome to this section where I'll be discussing repeat questions of the NEET exam. First of all, I would like to tell you that it's a great thing that you have reached this section of the after completing the main lectures. So that's great. I would like to congratulate you, but that is completing only one leg of the race. As they say, picture abhi baki hai. So part two of the race is gonna be that you have to be very thorough with questions of the previous year. So welcome to this section and let's get started with the very first one that they had asked. In this question, he had mentioned about a 65-year-old man who was presented with development of sudden onset nystagmus, limb ataxia, and dysautokinesia. Dysautokinesia would mean breaking up of complex movements, like we can do supination, pronation. Alternatively, a person who's having these three features together definitely points to cerebellar lesion. Now let's attempt the choices. He says which is the likely artery to be involved. So the question is dealing with a cerebrovascular accident, and our objective is to narrow down to the best possible explanation for this kind of a presentation. You are very well aware that anterior cerebral artery will mainly present with either monoplegia, like if the left anterior cerebral artery is involved, then the person would be having paralysis of the right leg and vice versa. Let us assume even if both anterior cerebral arteries are involved, person would be having paraplegia. Along with this, frontal lobe manifestations like abulia or aggressive behavior or incontinence would definitely start coming in the person. The reason for incontinence is damage to the paracentral lobule. Remember, paracentral lobule also comes under ACA territory. So A is not an answer to this question primarily because the clinical manifestation of anterior cerebral artery does not fit it. When it comes to middle cerebral artery, it will always present with contralateral face and especially arm weakness. There would be truncal weakness also occurring in the patient, but then primarily it's facial asymmetry and arm weakness that is very easy for the patient and the family members to identify. Along with this, aphasia can occur, apraxia can occur, hemi-neglect can occur. So B is also unlikely to be an answer to this question because the clinical picture does not fit. When it comes to posterior cerebral artery and internal carotid artery, how would you come to the answer? You see, internal carotid artery is the one that would give rise to anterior cerebral and middle cerebral. So if it is an internal carotid artery stroke, then the features present in the person could be combination of A plus B, that is option number A and B. So even if I am not aware of the fact that posterior cerebral artery can contribute to non-Thangel syndrome, non-Thangel syndrome has been discussed in the main section of the app. I'll just focus on the salient features here. Posterior cerebral artery has branches like P1 PCA, P2 PCA. If P1 PCA component of posterior cerebral artery, the P1 segment is compromised, it is thrombosed or there is an embolus from atrial fibrillation, let me say, or atherosclerosis of the carotid artery, the moment this blood vessel will get blocked, then there's a possibility that the blood supply of the superior cerebellar peduncle and the third nerve nucleus can definitely get compromised. Because of the damage to the superior cerebellar peduncle, there would be a contralateral, mark my words there is a contralateral limb ataxia and other manifestations like nystagmus and dysautokinesia that can come up in the patient, cerebellar manifestations. Due to third nerve palsy, obviously the manifestations would be in the form of ptosis and even a possible squint developing in the person. You see, whenever it's a brainstem stroke, it will always cause crossed manifestations. Crossed would mean that if on one side cranial nerve is involved, on the contralateral side there could be hemiplegia, it could be ataxia manifestations. But the bottom line is this that I've explained to you, and what was asked in your exam was actually a named syndrome. The name syndrome that you're aware of is non-Thangel syndrome. So the bottom line is that yes, we do have cerebellar manifestations with midbrain stroke. I repeat the features once again. Non-Thangel syndrome has been discussed in the section in the main app in stroke. You can just scroll down and you will notice midbrain stroke topic written. In midbrain, the blood supply is P1 PCA, and because superior cerebellar peduncle connects the midbrain to the cerebellum, because cerebellum needs continuous input. That is how it will maintain output or maintaining balance. So the bottom line is that cerebellar manifestations can be seen due to involvement of the P1 branch of the posterior cerebral artery. And I'll just show you the reference also. This is from a neurology book. I'll show you Harrison reference also. But then you all have read about Claude syndrome and Benedict syndrome, and then even about non-Thangel. The bottom line is I'll explain what Claude syndrome here is, but I just want to bring to your notice the fact that when it comes to non-Thangel syndrome or when it comes to Claude syndrome in a patient, there could be cerebellar manifestations occurring in a patient. These could be in the form of ataxia, dysmetria, dysautokinesia. The standard cerebellar manifestations can be present. Now, what is Claude syndrome? So let's just do a quick recap. You see, the midbrain stroke topic has been extensively asked in the exam, and now they started asking pontine stroke. But the point is, you see, medullary stroke, lateral medullary syndrome, Wallenberg syndrome, that everybody knows. So most of the time in the exam, you will see nowadays they started asking about midbrain and pontine stroke, and I'll try to give you inputs, salient features that you can crack the question in the word go right now. So listen to this with care. You see, Benedict syndrome is also an example of a midbrain stroke. The structures which are involved here is third nerve nucleus. It has to be third nerve nucleus whenever midbrain is involved. And along with that, there is also involvement of the red nucleus. Now, what the red nucleus does is that it connects it to the basal ganglia. So the manifestations that will develop in this person would be that a third nerve palsy, that is ptosis and squint. And because of the red nucleus getting involved in the person, the manifestations could be in the form of contralateral chorea or ethetosis. So do not be surprised if you read about chorea in midbrain stroke. That's because of the Benedict syndrome manifestations. In contrast, what I was speaking about and what was asked in your exam was basically they did not give the name obviously because that would have been piece of cake for you. So what they did was they asked about non-tangential, and the structures which are involved here is third nerve obviously because midbrain is involved, and along with that involved is superior cerebellar peduncle. So the manifestations occurring in this person would be third nerve palsy with a contralateral, remember my words, the lesion that is present here is after the decussation of superior cerebellar peduncle. The controversy with anatomy is anatomy people will say ipsilateral, but if you check Harrison, and I think for the exam you should follow Harrison, it categorically mentions that the lesion occurs distal to the superior cerebellar peduncle. So therefore the answer would be contralateral ataxia. It is not ipsilateral. I agree to the controversy with anatomy, but believe me, if you go by Harrison, then this is what is present. And then what is Claude? I want you to remember that Claude syndrome is a combo of the two which are written above. That is, if you have a combination of Benedict and non-tangential, then you call it Claude syndrome. What I basically want you to understand is that midbrain stroke can contribute to development of even cerebellar manifestations in a person. The blood supply of the midbrain is P1 part of posterior cerebral artery. The P2 is going to supply the occipital lobe, no? That you are anyway aware of. So P1 segment gets involved and any of these manifestations could be occurring. In 2019 NEET, they have asked about Weber syndrome. Weber has third nerve palsy with contralateral hemiplegia. So if you've gone through the 2019 paper, you will notice they asked about midbrain stroke. The topic asked was Weber syndrome. I repeat that again, I'm not writing Weber because that I have already covered in 2019 segment. That is third nerve palsy with contralateral hemiplegia. And the other features are the ones right before you. So if you go back to this question, you can very well see that the moment you read about cerebellar manifestations occurring in a person, that is sudden onset. One, it could be cerebellar stroke, right? But that would be again easy for you. So he wants to see that are you aware that even P1 PCA, that's the midbrain supply getting compromised, can contribute to cerebellar manifestations in a person, and the lesion primarily is in the superior cerebellar peduncle for this question. The answer to one is C. Coming to the second question, it talks about a 70-year-old man having nasal regurgitation of fluids. The moment you read that, you know very well that you are dealing with ninth nerve palsy. That's a classical presentation, nasal regurgitation of fluids and hoarseness of voice. Now, for hoarseness of voice, because there are so many reasons ranging from laryngitis to even vagus nerve involvement, so I'm just keeping at the back of my mind that probably in this question, vagus is also getting involved. On sensory examination, the numbness and sensation over the left of the face is affected. I would suggest you that whenever you are dealing questions of stroke, when it comes to left and the right side in the exam, you won't have the luxury of drawing anything, but you should try to draw a mental diagram of what is the lesion, on which side the lesion is present in the person. So he's saying that there is numbness and loss of sensation, that is like touching is there. So on the left side of the face, like the touch sensation is gone. Then he also mentions the fact that on the contralateral side of the body, it is only pain and temperature which are affected. The moment you read only pain and temperature, just put a dotted fashion to highlight that here the main sensation affected is pain and temperature. So this tells me immediately that he's talking about spinothalamic tract getting involved in the person. You can also notice that I have drawn crossed manifestations here. What I mean by crossed here is that one side of the face, one side of the body is involved. The involvements are different. Like on the face, there's complete numbness, all sensations are gone. In the body, it's gonna be only pain and temperature. But the moment I read about crossed manifestations, it always tells me that brainstem is involved. The classical manifestation given in this MCQ is that of crossed hemi-anesthesia, which definitely helps us in arriving at a question's answer. But let's read on. He talks about motor examination showing a left arm weakness. So there is definitely either corticospinal pathway or maybe some cerebellar involvement. He says cranial nerve examination shows a diminished gag reflex. Now this gives credibility to the fact that ninth nerve as well as 10th nerve is affected in the person, because absent gag definitely tells you that the brainstem, that is medulla, is involved. So on reading this question, the impression of mine is that this person is having medulla involvement. Why? Because 9th and 10th nerve cranial nerve palsy is given in this question. Along with that, there is a crossed anesthesia. There's definitely a spinothalamic tract involvement in this question. Based on this fact, what should be the answer? Well, it cannot be posterior cerebral artery. Why? Because I've explained to you that posterior cerebral artery involvement can still cause manifestations of either Benedict syndrome or Claude syndrome. Third nerve palsy, I mean the keyword why B is not the answer is third nerve palsy is definitely not given in this question. It's 9 and 10th. Middle cerebral artery will always contribute to contralateral face paralysis. Then there could be features like aphasia, apraxia, heavy neglect. So two options are off. You're left between PICA and AICA. Now, why AICA is an answer or is not an answer to this question? Let's work it out. Anterior inferior cerebellar artery is a branch of basilar artery. And well, what does it supply? It supplies the pons. You see, in this particular question, how am I ruling out is based on combination of internal medicine and anatomy. The bottom line is that AICA, you all know, is a branch of basilar artery. It supplies the pons. It basically supplies the inferior part of the pons, and ninth and the 10th nerve does not originate from the pons. Ninth and the 10th nerves originate from the medulla, and the blood supply related to medulla is PICA, that is posterior inferior cerebellar artery. So please remember the fact that, do remember the specific statement that I mentioned, that whenever there is AICA involvement, it is inferior pontine syndrome. What are the cranial nerves that can be involved here? It could be fifth nerve, that is sensation on the face. Seventh nerve, motor supply of the face. So five sensory and seven motor would be affected. Even eighth would be involved because eighth nerve vestibular nucleus can be compromised. Along with this, there could be crossed hemianesthesia. So you are seeing the fact that crossed hemianesthesia can be read by you not only in pica involvement. Mark my words there. Crossed hemianesthesia can not only be found in pica involvement but can be found even in AICA involvement. So how did I differentiate? I differentiated on the basis of the cranial nerves involved. When it comes to lateral medullary syndrome, you see the clinical profile of this particular question is related to medulla. It is lateral medullary syndrome. What are the nerves which are involved in lateral medullary syndrome? Then it is 5, 7, 8, 9 and 10 also. You see, the key of this question is rather why the answer is not AICA is because AICA can also contribute to cross anesthesia. It can even cause face sensation loss. Even features of spinothalamic tract involvement is present in AICA involvement. But then how to rule it out? In AICA, there should be involvement of 5, 7 and 8. Not given here. Rather, it is 9 and 10 which is given here, which rather tells us that the lesion is below the pons, that is in the medulla. The correct answer to this MCQ is alpha Wallenberg syndrome, a hot favorite of our examiners. But we had a couple of learning lessons here, so let's just put that to practice. The basic concept I want you to understand is that AICA, anterior inferior cerebellar artery, is a branch of the basilar artery. On the other hand, you are familiar with the fact that PICA is a lateral branch of the vertebral artery. In case AICA is involved in a person, because it is running laterally from the basilar artery, so it is contributing to lateral pontine syndrome. It is actually in lower part of the pons, so lateral inferior pontine syndrome. And pica involvement, which is a branch of the vertebral artery, you are anyway aware that would be contributing to lateral medullary syndrome. When it comes to the common thing between the two, would be both of these diseases can be having crossed hemianesthesia. That is, on one side of the face, all sensations would be lost, and in the body on the opposite side, only two sensations would be lost. Only pain and temperature. So that's why the word is crossed hemianesthesia. Apart from this, what you also need to understand is that AIC involvement can be having involvement of 5, 7, 8. When I'm talking about 5, it is 5 sensory and it is 7 motor component which is affected. Let's look at what is involved in pica, cranial nerves. It's 5, 7, 8, 9, 10. Do remember the fact that here 5 sensory is involved, but 7 that is involved is not motor, it is 7 sensory. That is why, no, if you go through the main lecture of pica involvement, I've talked about agesia. The taste sensation is affected. Even ninth glossopharyngeal component is gone. Vestibular system can be affected. Ataxia could be developing in the person, one because of vestibular component, and second could be obviously cerebellar involvement, or connections with the cerebellum are also affected. A restiform body is affected. The bottom line that I want you to remember is AICA involvement and PICA involvement both can contribute to common clinical manifestation of cross-term anesthesia. The differentiating feature is in the cranial nerves that are involved. And in the question that came in the exam, because he had given information for especially the ninth and the 10th nerve involvement, that is why the answer has been localized to pica involvement. Had this not been given, had he spoken about 5, 7, 8, 5 sensation of one side of the face, 7 motor, or that is one side of the face, motor supply is gone, and then 8th involvement is vestibular, that could be vertigo, nystagmus, rather dizziness, room spinning around sensation with cross-term anesthesia is a feature of anterior inferior cerebellar artery involvement. So answer to question number 2 is A, and I've been a little descriptive, but I hope it should be worth this effort. A 30-year-old female complains of fatigue and is unable to gain weight. On examination, her body feels warm. So we are talking about gender female. We are talking about rather failure to gain weight. So either the weight of this person is static, right? Or it could be even having a decreasing trend. So though the question is not mentioned a decreasing word, but at least the person is concerned about the fact that she's always tired and her weight is on the lower side. And her body temperature is rather elevated. So either she's having some infection contributing to low grade fever, or it could be a possibility that she's having some autoimmune disorder which is causing basal metabolic rate to be more. Well, you can understand because the question is giving options of thyroid hormones. Therefore, we are talking about here is Graves' disease. In a young female reproductive age group, Graves' disease could be present, and Graves would cause autoimmunity to rather cause overproduction of thyroid hormones. So T4 and T3 will definitely increase because the autoantibody, the name of the autoantibody is long acting thyroid stimulating antibody, that the antibody has chemical structure like TSH. So it will stimulate the gland and it will cause overproduction of T4 and T3, and by feedback the TSH values will become relatively lesser. So if you look at the options here, option A says high TSH with normal T3 T4. Unlikely, no, Graves does not have a normal T3 T4. So option number A is ruled out. And anyway, where do you get option number A? You get option number A with subclinical hypothyroidism, especially in young females who are having weight on the higher side and menstrual abnormalities. Lots of time in this young female who's having weight on the higher side and menstrual abnormalities, if you get thyroid function test done, you will notice that T3 and T4 is normal, TSH is elevated. That is primarily subclinical hypothyroidism and usually does not require treatment. If the value of TSH is more than 10, then treatment of subclinical hypothyroidism is given, but otherwise routinely there is no need except for monitoring the patient. So option A is ruled out because that is lab profile of subclinical hypothyroidism. When you say high TSH with euthyroid state, that basically is same as option number A. So A and C are basically meaning the same only. We have the answer before us anyway. That is option number B. Low TSH with high T3 T4 is a presentation of what we call as primary hyperthyroidism. So to get my terms right, primary hyperthyroidism basically implies that there is an autoantibody. The name of the antibody is LATS. The chemical structure is like that of TSH, so it continuously stimulates the gland, overproduces T4, T3, and the TSH values would downgrade and might even become undetectable in this particular case. The key to this question was rather the increased basal metabolic rate, because of which the lady is not able to gain weight, or it could be weight loss pattern, and along with that body temperature is elevated. So though the information given is sparse, considering the options and the clinical profile given, we can suspect that this lady could be having a query Graves. And how do you know it is Graves? Obviously, you need to do a thyroid function test and antibody titer, and that is how you would be able to localize the disease. So the correct answer for question number 3 is option number B. Coming to question number 4, he talks about the commonest endocrine tumor of the pancreas. Do remember that this is a fact-based question. Overall, when it comes to pancreatic tumors, you are familiar with the fact that it is non-functioning tumors that are common. PPoma is the word written. I'll show you a Harrison snapshot for the same as well. But then after non-functioning tumor, the common one is insulinoma. So in this question, your eyes should be hunting for the answer. That would be option number C. Pretty a straightforward one, I would say. The Harrison snapshot you can see here highlights the fact that when it comes to incidence, out of all the tumors that are given, whether it be Zollinger-Ellison, VIPoma, somatostatinoma, and I've described these neuroendocrine tumors in the early section, or rather in the first chapter of endocrinology. So you can go through it at maybe 2x at this point of time and just go through the salient features. Especially for insulinoma, I think you all remember that test, no? A very particular one that they asked, 72-hour prolonged fasting test. It's not that you are keeping some guy hungry for 72 hours, but I have discussed the technical aspects in the main app section. I suggest you to go through that neuroendocrine tumor section in internal medicine as well. Apart from surgery, I assure you the fact that with listening to that, your strike rate will definitely be increased. The incidence is 1 to 2%. Let's compare this with non-functioning adenoma. Look at the figures. He's still giving 1 to 2%. But mostly textbooks are first mentioning the name of non-functional tumor and then is mentioning insulinoma. So that is how you're supposed to remember overall non-functioning. If he says the word functioning, then it's cool. I mean, your answer is insulinoma. And in your exam, if you look at the options, he did not trouble you much. He simply said which is the most common endocrine tumor of the pancreas. Well, piece of cake, insulinoma. Coming to the next question, it talks about which is the most common site of gastrinoma in men 1 syndrome. You're aware that men would be having 3 Ps. Let's have a quick recap, 30 seconds. That would be one would be a pituitary adenoma. That was gonna be a prolactinoma. The second P is gonna be a parathyroid adenoma. That will spike up the values of PTH and contribute to hypercalcemia. And then would be pancreatic adenoma. Now, when it comes to a pancreatic tumor, I have discussed with you overall functioning one is insulinoma, but with respect to multiple endocrine neoplasia type 1, the pancreatic tumor that is to be remembered is Zollinger-Ellison. The question went a step ahead. He said, what is the location of Zollinger-Ellison? So that's going to be duodenum. Remember, G cells are max in the stomach. With the tumor of G cells, gastrinoma is not in the stomach, it is in the duodenum. The answer to question number 5 is Bombay. That was again, I would say, well covered in the GI section of the app. You can go through Zollinger-Ellison syndrome. In fact, in the GI section, I mean, one thing that I definitely want you to revise 1 month before the exam is Zollinger-Ellison, because, and couple that with surgery, because Zollinger-Ellison, I have usually found the questions usually come on this topic, and it's pretty a straightforward one. And do remember aspects like tumor localization of Zollinger-Ellison is done with endoscopic ultrasound. I have highlighted the incidence of insulinoma, but I am now highlighting the fact that when it comes to especially the aspect of Zollinger-Ellison, then ZES is commonly located in the duodenum. It could be first part of duodenum, second part of duodenum, and the incidence is more as compared to that in the pancreas. In fact, gastrinoma triangle is the one where this would be located. And for medical management of this, we will be using octreotide. We have to use PPIs for the person. And the clinical profile of gastrinoma is also very interesting. He'll always say a few words, which I'm going to write before you. If you get a question where features of peptic ulcer disease are given, epigastric pain, bloating, discomfort after eating food, headache which would occur due to gastritis, but then adds the fact that the person is having secretory diarrhea as well. This tells you the fact that this question is not related to routine H. pylori induced peptic ulcer, because you don't have a secretory diarrhea. So if you're having peptic ulcer disease manifestations which are usually recurring after stopping PPIs, like you gave a course of 4 weeks, 6 weeks of PPI, you stop it again, the features come back. So refractory peptic ulcer disease, if refractory word is given cool, usually he'll not give it, no, because that makes a piece of cake for you. So then remember, the combination of the two is where you have to consider Zollinger-Ellison syndrome. The test that we use for localization is endoscopic ultrasound, and Where will it be located? Mostly it will be found in the duodenum, either in the first or in the second part. Or he can ask you about the investigational choice for Zollinger Ellison syndrome. I think everybody remembers that. That is secretin study. In secretin study, we are going to study or evaluate BAO, MAO. We're going to talk about fasting gastrin levels, and all of them are going to be spiking for this fellow. The details of this are given in the Zollinger Ellison lecture that I've shot in the GI section. The answer to our question is option number B. I repeat the question once again. The commonest site for Zollinger Ellison syndrome in men 1 is going to be duodenum. Otherwise, also is duodenum only. Coming to question number 6, he talks about a 35-year-old man with intractable diarrhea. Guys, my humble request to you is go through the last lecture in the app AIDS at 2x speed. I have covered all the opportunistic infections there, and 1 to 2 questions on AIDS opportunistic infections are always asked. So I would definitely like you to go through that. That would help you in refreshing your microbiology component as well. Now he's telling you that this chap is having diarrhea, he's having abdominal pain, vomiting. So features mainly point to that of small intestine, or it could be large intestinal involvement also. And he's talking about cyst which is less than 10 micron in size. Now if you look at the image, and I had a chat with the pathologist also, they said from the image that actually came, you can't make out whether it is small intestine or large intestine. So there can be two possibilities. One possibility is that he's having a AIDS defining illness, and one of the AIDS defining illness is cytomegalovirus colitis. And another cause that can contribute to diarrhea in AIDS positive patient is cryptosporidium, and both of them are given in the options. So let us try to resolve the issue. When it comes to cytomegalovirus colitis, then he should definitely show you a particular cell. This cell would be having a nucleus, and well, inside this nucleus you would be having basophilic owli appearance. Now, if you look at these big cells which are present here, these cells can be thought of as maybe having a owli appearance, and a couple of people actually marked it as cytomegalovirus colitis in the exam. But even if you look at this high power image, you will notice that at least the routine owli appearance of basophilic inclusions inside the nucleus of this of any of the cells is not visualized. What you can definitely see is a couple of cysts which have been marked as less than 10 microns. Whether this is small intestine or large intestine, well, that is subject to debate. But assuming the fact that the person is having cryptosporidium diarrhea, I can say that if there is blunting of villi, it would be difficult to identify the small intestine. What are these blue things that you're seeing? So these could be lymphocytes that are infiltrating the lamina propria. So this image per se is showing blunting of the villi. This is showing infiltration of, especially I would say, lymphocytes. This could be plasma cells in the lamina propria, which normally is not going to be present. And then he's talked about a cyst also, which will help you in diagnosis. The answer to this question would be given as option number C, that is Cryptosporidium parvum. You can solve this question even by a simple statement. Now, the leading cause of diarrhea, one of the leading causes of diarrhea in an AIDS positive patient is Cryptosporidium parvum. Now, why Isospora belli is not the answer to this question, because even here you could be having cysts in the gut, and even that can contribute to opportunistic infection in AIDS. But the size of the oocyst which is present is relatively bigger. Usually it is 30 into 12 microns. So please remember the fact that the size of the cyst in Isospora belli is relatively, I would say, 3x of that of what is seen in Cryptosporidium parvum. I'm ruling out A in the question. Why? Because I cannot visualize owli inclusions, and features of colitis would even have dysentery, which is not given in this question. Giardia lamblia is usually a cause of campers diarrhea. Like a couple of guys, they went to some hill station for camping or trekking, and there was no water, so they ate food or snacks without washing their hands. So campers diarrhea is what we usually see, or in trekkers we see diarrhea occurring, maybe because of Giardia lamblia, and that responds very well to metronidazole. The correct answer to this question is C, and I would like to spend a few more minutes into this question just to give you a better overview. Please remember the fact that when it comes to GI infections in a AIDS positive person, they love to ask regarding Cryptosporidium parvum and the treatment for it. They also like to ask regarding cyclospora. the size of the oocyst will be relatively bigger. And then I spoke regarding Isospora belli, which was one of the options given in this question. Now, when you compare the size of the oocyst, which is found in the gut specimen, and the stain that is usually used when it comes to all of these, because these are mildly acid fast, so most of the time the stain that we use is called as quinine stain. Now the size with respect to cryptosporidium is relatively one of the smaller ones, that would be 4 to 8 microns. For cyclospora, this would be approximately 8 to 10 microns. And isospora is huge, I mean the biggest of them, that would be 30 cross 12 microns. So therefore I can say the fact that the size of the cyst will definitely matter in the exam. In fact, in the AIMS exam, they have asked the same question but in a different way. That is a two-step question. They have first mentioned the size of the cyst themselves. They described the AIDS positive person having diarrhea episode. They described that there are cysts visualized. They just gave an image and they asked what is the treatment. So when it comes to Cryptosporidium parvum, the molecule that is going to be used in AIDS positive patients, remember, otherwise it is parmomycin, but here what you will answer would be nitazoxanide. So remember my words there. Cryptosporidium parvum is overall opportunistic infection in AIDS positive persons. Nitazoxanide is the drug treatment for it. What do you use for cyclospora? You would be using cotrimoxazole. That is the one that we refer also as Septran casually. And the same treatment is also going to be given for Isospora belli. So in the question, be careful with the fact that if he is going to talk about Cryptosporidium, it is nitazoxanide. If it is Cyclospora or Isospora is 3x the size, then it's going to be cotrimoxazole. Another organism that I have found and they started asking, especially in AIDS positive patient, is microsporidosis. I would request you to go through and brush up the micro component related to this also. Even if you don't know, just listen to the AIDS opportunistic infection section. In the last infection section, I have talked about AIDS. And if you listen to 2x, you can cover it in 1 hour. And that will definitely help you refresh your micro section and would also tell you, do you need to go back to the micro section again or not? Because if you know everything that I'm saying in that section, it means that your micro part is fine. But otherwise, you need to go back and just brush up the facts. For microsporidosis, guys, the drug of choice to be used and answered is albendazole. I repeat the statement once again. The topic that I've explained to you here is GI infections that are usually found in AIDS positive patients. In fact, they have become bored of asking about pneumocystis jirovecii and tuberculosis. So nowadays, they are rather asking you about GI infections in AIDS positive patients. As far as Giardia is concerned, I have already highlighted that before you, that Giardia would be causing Camper's diarrhea, and Giardia has a very particular appearance also. No? In fact, I can draw it here also so that I can highlight it. Well, I can say that the organism would be having a very particular appearance that is referred to as clown face appearance. That's itself a question. When it comes to giardiasis, you can notice a little bit of infiltrate present in the lamina propria component at low power, and then the organisms are found in the lumen of the gut and they contribute to again villi atrophy on the long run. One infection is definitely not going to cause a villus atrophy. Clown face appearance is present, and campus diarrhea is the one that would be the usual presentation. The tests used are multiple for this, and you are aware of the motility parts, though you can go through the microbiology section. And then if he talks about the AIDS positive person, talks about the fact that this person is having features even of dysentery, abdominal pain, and this has been persisting in spite of taking routine treatment like metronidazole or ornidazole course has been prescribed. And then at high power, you are able to visualize cells which would be having a nucleus, and inside this nucleus you can see these basophilic big inclusions. So here you can see that I have highlighted what I was saying earlier, the owl eye inclusions. This is going to point towards diagnosis as cytomegalovirus colitis, which is one of the AIDS defining illnesses that you basically need to remember. So I have tried to cover details related to the four options here. Let's have a quick recap on this question. Overall, the leading cause of diarrhea in a AIDS positive patient is Cryptosporidium parvum, and the size of the cyst is less than 10 microns. So that's why this question's answer is C. Uh, Option A is ruled out because it's not talking about dysentery manifestations. There is no owl-eye appearance that could be visualized. Option D is ruled out because of the campus diarrhea component, and you can differentiate between B and C on the size part. So therefore, the answer is right before you. Coming to the next question, he talks about all of the following are features of left ventricular failure except. You know the fact that LVF will always contribute to pulmonary edema, and that will make bronchovascular markings become rather more prominent. So when the markings in the lung are rather more prominent, the technical term that we use is called as pulmonary plethora, which means that there is congestion of blood in the lungs. Option A says lung oligemia. That is looking like to be the answer to this question right away, but let's go to option B. Curly B lines always are a feature of pulmonary edema. And where do you check for curly B lines? So on a chest X-ray, curly B lines will always be present perpendicular to the pleural surface. You see, if you see a chest X-ray of a normal person in the extreme lateral aspect, you see the area which is closest to the heart. Let me just divide this artificially into three zones, that is A, B, and C. So I would like to highlight this is zones, right? I'm not talking about curly B, or curly C. What I'm saying is, if I look at area A, which is closest to the heart, that is where the whiteness is seen. That's where the blood vessels are seen in UN. When it comes to B, the blood vessels become thinner. But if you come to the periphery of the lung, that is area number C that are delineated, there are no blood vessels, absolutely no blood vessels seen in zone number C of the lungs. But if you are seeing some blood vessels here, then we call it curly B lines. Mark my words here, the ABC that I've written here is just to compartmentalize the lung, the area closest to the heart, a little away, and the one towards the periphery and close to the chest wall. So ABC here represents the zones which I've just used artificially. Otherwise, the location of the curly B lines is perpendicular to the pleural surface, and that's a feature of pulmonary edema. So B is definitely a feature. Crepitations, yeah, again is a feature of pulmonary edema. These are fine crepitations, like you open a Velcro tape, that kind of sense sound would be produced. And then pedal edema. Well, what I can say is that left ventricular failure is the leading cause of right ventricular failure because the two chambers are coupled to each other. If left will fail, right will definitely fail, and that will contribute to elevated JVP. It will also contribute to hepatomegaly. This would be a tender hepatomegaly because there would be a stretching of the capsule of the liver. And along with that, there would be a pedal edema component coming in also. So you can see that pedal edema is also a feature that could be seen in patients who are having left ventricular failure. The correct answer to this question is alpha lung oligemia. The bottom line is that whenever you have heart failure, there's rather congestion in the lungs. There's a pulmonary plethora, and here he has written the term oligemia. So because of this particular word, this is not a feature of congestive heart failure. The answer to question number 7 is alpha. I have also introduced here a couple of images which will make you understand the term pulmonary plethora relatively better. If I just zoom it in, you will notice that there's a definitive haziness, and that's definitely much more than normal haziness in the pericardic areas, and that's because there is congestion in the heart looks relatively dilated, and along with this, the pericardiac shadows are enhanced. And gradually, what's going to happen is that this whiteness will increase to the periphery, and that's what you read as bat wing pulmonary edema. So I just wanted to highlight that whenever you read the word plethora, it would mean there is more congestion in the lungs. Congestion would imply that the pulmonary veins are overloaded. The hydrostatic pressure is increased, so the fluid will leak out into the alveoli and will contribute to cardiogenic pulmonary edema in a person. I would also like to use this opportunity to show an X-ray before you, where you will notice that the lungs look relatively more black than normal, and there is also flattening of the diaphragm. Now, why I've shown this X-ray is because you can notice that in this X-ray, rather the heart is looking relatively smaller. If you compare the image that you can see on the left, you will notice that here the heart looks relatively smaller. That is the tubular heart. The lungs appear relatively black. The reason for blackness is not that the vascularity is reduced, rather it's air trapping. And how do I know it is air trapping? There's definitely flattening of the diaphragms. So this image on the extreme right hand side is what I have just introduced for comparison. And this image, the findings that I've highlighted would point towards diagnosis of emphysema. Now, the reason I've introduced this image is only to sensitize you to the fact that whenever you're seeing an X-ray, you have to look at the X-ray from the totality in a perspective of the lung field's appearance, the diaphragmatic position, and then the size of the heart as well. If you get an image where you can see that the size of the heart looks relatively bigger, and you can definitely notice some parahilar congestion present, that is more in favor of cardiogenic pulmonary edema in a person. Lots of time in the exam, because congestive heart failure is a topic that is always asked, I would suggest you to go through the CHF section at least at 1.5 or 1.8x and just go through the selective aspects that I've highlighted, especially for treatment of conditions like heart failure with preserved ejection fraction. I have discussed aspects related to heart failure with reduced ejection fraction. Here I can use this opportunity to mention that for heart failure with preserved ejection fraction, we shall mainly be using ARNI, that is valsartan with sacubitril, and we will be using aldosterone antagonists like spironolactone. And for heart failure with reduced ejection fraction, if there's a volume overloading, we can be going in for LMNOP. That is Lasix, morphine, nitroglycerin, oxygen and positioning. You can go for non-invasive ventilation. If it is cardiogenic shock, you could be using molecules like norepinephrine or dopamine or dobutamine or even impella or even intra-aortic balloon pump. So do go through the heart failure component, and the bottom line is that there is excessive congestion in the lungs. The term used is plethora, and in this question, I'll just show the options once again. Oligemia implies less blood supply. Where do you get lung oligemia? You get that in cyanotic heart diseases. Conditions like tetralogy of Fallot, tricuspid atresia, Epstein anomaly, those are the conditions where rather the pulmonic blood flow is reduced. The inflow into the pulmonary circuit is reduced. And that is why that's a hallmark, right? I mean, lung oligemia as a feature is mainly seen in cyanotic congenital heart diseases. Answer to 7 is alpha. Coming to 8, he talked about nosocomial infections. He simply asked about the cutoff. So the answer would be 48 hours. That's pretty a straightforward one, fact-based question. And let's just quickly revise what does he mean by the word nosocomial. So one is definitely a infection that occurs with respect to after 48 hours of hospitalization. Because if somebody develops, suppose I'll give an example, somebody is admitted for gallbladder surgery. Gallbladder surgery was cancelled because of, let me say, COVID or due to any administrative reasons. So if somebody develops features of lung infection within something like 24 hours, 48 hours of hospitalization, he could be carrying the infection from the community from his house. But if a person is having a development of a new infection, like this person was admitted for elective surgery, the elective surgery got cancelled on 2 consecutive days or 3 days, but after 48 hours of hospitalization, if there is a new onset infection developing in a person, we call it nosocomial. There's an alternative definition also. That is, if a person starts getting infection that is in the form of pneumonia within 3 days of discharge, like this person was admitted in a hospital for hernia surgery. He had a direct inguinal hernia. He was a person of, let me say, obesity with constipation, and he had a DIH, a direct inguinal hernia. You did a repair and you discharged him, and then subsequently within 3 days of discharge, a person starts having a pneumonia manifestation. That is, he carried the infection from the hospital back to his house, or an infection that occurs within approximately 30 days of a surgery. So whenever you gonna read these terminologies that I've highlighted before you, we tend to call it a nosocomial infection, out of which what he has asked is one primarily for 48 hours. And well, we have two important infections here. One could be Staph aureus, and then could be streptococcus pneumoniae, which can contribute to even a pneumonia manifestations, which could be dangerous enough to even cause death of the person. Answer to question number 8 is C. Coming to question number 9, he says which of the following is not a criteria for diagnosis of metabolic syndrome. Now, metabolic syndrome is very common in India, especially in middle-aged males. So, what would happen in metabolic syndrome is that this person will start having tummy fat. You see, centripetal obesity is more dangerous than subcutaneous obesity. I can give examples: sumo wrestlers. Sumo wrestlers, like they train in Japan and they eat a lot of, like they eat 10,000 calories a day, but at the same time they do exercise also. So they have a lot of sumo wrestlers have a lot of subcutaneous fat, and they usually do not develop heart disease. And one reason for that is obviously because Japanese eat a lot of fish also, and fish would be having omega 6, omega 9 fatty acids. So that definitely reduces the incidence of heart disease. But I want you to remember the fact that subcutaneous obesity is less dangerous than centripetal obesity. So tummy fat is bad. So what happens is that if abdominal circumference increases, if abdominal circumference increases more than 90 centimeter in an Indian male and more than 80 centimeter in an Indian female, then it indicates centripetal obesity, and that will do also an increase of peripheral resistance in the body. This increase of peripheral resistance will contribute to hypertension, which is the second manifestation developing in this person. In fact, India is having an epidemic of metabolic syndrome. There is an increase in the tummy size, there's an upgrade of peripheral resistance that contributes to hypertension in the person. Along with this, because the person is becoming relatively obese, there will also be insulin resistance. This will contribute to the fasting blood sugar of this person coming in the range of 100 to maybe 125, and a 2 hour value that would be coming something in the range of 140 to 199 milligram percent. That indicates impaired glucose tolerance. There is a definitive insulin resistance. You will also notice that the lipid profile of this person will be diminished. The lipids will definitely be increased. And what would be increased in lipids? It is the triglycerides that would be elevated, and it is HDL, the good cholesterol, that will be substantially reduced in these persons. So what I want you to understand, how do you remember it? It's a guy who's having more weight, who's having rather more blood pressure, having higher sugar values and a deranged lipid profile, and you can see that LDL is definitely not a component of metabolic syndrome. The correct answer for this question is option number delta. Normally we talk about bad cholesterol being the villain, but here you can see that it is triglycerides and rather the downgrade of the good cholesterol that is problematic in this person. Metabolic syndrome is also referred to as syndrome X. So both terminologies should be known to you, and you should not confuse it with coronary syndrome X. I hope you remember, right? Coronary syndrome X is gonna be related to the smaller branches of the coronaries. I am talking about ultra small blood vessels. The ultra small blood vessels are called as perforators. So if the ultra small blood vessels, that is the perforators, will become narrow, the narrowed perforators will definitely cause problems in the patient. I repeat my statement once again. When it comes to coronary syndrome X, it is the perforators which will become relatively narrowed, and once the perforators get severely narrowed, then there's definitely problem in the person, that the features that will be present in the person would be chest pain on exercise. So features will be that of chronic stable angina, but the treatment of coronary syndrome X cannot be balloon angioplasty. Balloon angioplasty is for narrowing of the main coronary artery. Here we talk about ultra small blood vessels. You can't dilate ultra small blood vessels. So it's only medical management. You will be using long acting nitrates for the person. You could be using new drug like ranolazine. So management of chronic stable angina is also nitrates, it's ranolazine, or we can use beta blockers for the patient. Similar kind of treatment would be given here also, but I want you to remember the fact that balloon angioplasty is not done in coronary syndrome X, and coronary syndrome X is different from syndrome X. Syndrome X is an alternative term for metabolic syndrome. And the problem with this guy, as I explained, was the tummy size is more, the peripheral resistance component is more, impaired glucose tolerance is present, and then there would be hypertriglyceridemia that will definitely contribute to accelerated atherosclerosis. The incidence of heart disease in metabolic syndrome is definitely higher. These patients could be having their first MI by anything between 50 to 60 years of age. You see, in America, heart disease occurs in 70s and 80s, but Indians develop heart disease earlier, and there are two important reasons for it. One, middle-aged men and women in India are having accelerated atherosclerosis because of the reasons that I mentioned before you, and along with that, homocysteine. Homocysteine is itself a risk factor for development of heart disease. Answer to question number 9 is delta, and I've just discussed a couple of allied details related to the question as well. Coming to the next question, he talks about frontal gyrus lesion leads to. So you can notice the fact that it was actually the inferior frontal gyrus that was asked, and that is the area where the Broca's area would be located. So if you're having damage to the Broca's area, the manifestation would be option number C here. Why answer is not A is because For Wernicke's aphasia, the damage should be occurring in the superior temporal gyrus. And actually, in the question, he has asked about damage in the frontal gyrus. When it comes to nominal aphasia in a person, I want to tell you that this is an alternative term for anomic aphasia. Let me explain like this. If I show you this pencil that I'm writing with, or if I show you a mobile phone of mine, if I ask you what is it, you will say it's some kind of a writing device, or you can say that this is a cell phone. I mean, if I ask you a question of a very common item, like if I show you a remote control of an air conditioner, you can look at the remote control and tell me it's a remote control. Now imagine a situation where I show you a cell phone. Your brain knows that this is a cell phone, but your brain is not able to is not able to pick up the words. I mean, you know it is a cell phone, you recognize it is a cell phone, but you are not being able to find the words, the correct words to say the word cell phone. What I'm describing before you is called as anomic aphasia and is alternatively also called as nominal aphasia. This is a feature that would be seen in people with hepatic encephalopathy. If a person is having ammonia intoxication, and if you show your cell phone to him, he will recognize it as a cell phone. But when you say, "What is it? Speak it out before me," he will not be able to select, his brain will not be able to select those words. I mean, something as simple as a cell phone. Everybody, even the poorest of a poorest person in India, knows what a cell phone is. But in this chap, you're showing him a cell phone, and he does not, from the look of his eyes, you know, he recognizes that this is a phone. But when you say speak what it is, he's not able to vocalize, he's not able to produce, his brain will fail to recognize or will fail to pick up the words. There is no problem of Wernicke's area, there's no problem with Broca's area, but the ability to pick up the words and give an answer is definitely lost. So anomic aphasia is alternatively also referred to as nominal aphasia. You need to remember both the statements. Nominal aphasia and anomic aphasia is a feature of metabolic encephalopathy. Metabolic encephalopathy would examples I can say are like carbon dioxide narcosis. Uremic encephalopathy, urea will confuse the brain, ammonia will confuse the brain, so the guy will be fumbling for words. And when it comes to the last option, akinetic mutism, that is what you get in Parkinson disease. In Parkinson disease, you have rigidity, so the body will become very stiff, and even the vocal cords are stiff. Akinetic mutism, I can give example of Muhammad Ali, the king of the ring, right? The king of the ring, who was a heavyweight champion for 10 years. These guys, they train so hard, and he had so much of punches to his head in his entire career that Muhammad Ali, towards the end of his life, remember, he died because of pneumonia. Muhammad Ali died because of Parkinsonism related complications. Like, he was the chief guest at the Olympics in Rio in 2016. Now in 2020, the Olympics were supposed to be held in Japan. They have been cancelled. But the Olympics in 2016 in Rio in Brazil, when Muhammad Ali was called on the stage, the king of the ring, right? Nobody could stand up to him. The king of the ring did not walk onto the stage. He was brought on a wheelchair. And when they put a mic on his face and said, "Sir, can you say a few words?" Muhammad Ali was not able to speak. The vocal cords of his were having rigidity, so he could not coordinate the pronunciation of words. So akinetic mutism, as you can understand, mutism, he can't speak. Broca's area is fine, Wernicke's area is fine, comprehension is fine, but vocal cords are not going to be able to do the task. So that's going to be akinetic mutism. Please remember, if cerebellar lesion is there, there's a dysarthria. Dysarthria means unclear speech. But akinetic mutism is a very characteristic feature, like the person will be wheelchair bound. He can't even say, "I need to go to the washroom." He can't say, "I'm feeling hot, switch on the AC," or "I'm feeling cold, switch off the AC." So that kind of a situation where person can't move his body and can't even speak is a feature of Parkinson disease. So answer to this question is option number C, that is Broca's aphasia. Coming to the next question, he talks about superior temporal gyrus lesion. You can very well see the area that is highlighted in this image. There was no image given in the exam. I've just put it here to sensitize you to the fact that it is superior temporal and inferior frontal gyrus. I'll just show the image once again. You can see it is inferior frontal gyrus, and that's for Broca's area, and Wernicke's area is gonna be the superior temporal gyrus. The question says it leads to, so the answer would anyway be a piece of cake, that is option number B. Some questions were very straightforward. No, these are the questions which you are like gifts for you. Like, you just need to collect those gifts. Anomic aphasia, well, I have explained to you, it cannot be the answer. Why? Because that's a feature of metabolic encephalopathy. Three examples of metabolic encephalopathy that I've explained to you are hepatic uremic encephalopathy, and carbon dioxide narcosis. Broca's aphasia would contribute to a person having inability to speak, because Broca's is for expression. Broca's is for fluency. Like I'm speaking fluently before you because my Broca's area is firing properly. But in a person who's having a definitive lesion in the inferior frontal gyrus, Broca's aphasia will definitely occur in the person. And when it comes to non-fluent aphasia, if you look at uh, option number C and D, they both mean the same, no? Because I just said Broca's area is for fluency. It is for syntax. In fact, I'll just write it down so that it makes more sense for you. Broca's area is for expression. If my Broca's area is gone, that means that I won't be able to speak. The fluency part would be lost. That's why we call it non-fluent aphasia. And then syntax means grammar would mean like past tense, present tense, so all of those would be compromised in the person. So option C and option D basically are same, and therefore you can see why B is the answer to this question. I would just like to use a different color to highlight that I have explained the fact that inferior frontal gyrus and superior temporal gyrus lesions would contribute to problems in a person. Why I'm doing that is because I am showing the M4 segment of the middle cerebral artery. You can study about middle cerebral artery in the very first lecture in neurology. It's just a 5-minute lecture, but go through middle cerebral artery anatomy. The M4 segment of the middle cerebral artery would be running like this. It will have a superior division on the cortex and it will be having an inferior division. So if the embolus or a clot is going to block the superior division of M4 segment of middle cerebral artery, you can very well see that if this is the embolus that's going to physically block it, then you would be having features of Broca's area being damaged, and that will contribute to a non-fluent aphasia. But suppose the embolus lands up in this area, then the Wernicke's area would be affected, and Wernicke's area is mainly for comprehension. It is mainly for understanding. On the other hand, if the embolus lands up in this area that is supplying the Wernicke's area, then the understanding part of the person would be compromised. Wernicke's area is mainly responsible for understanding a speech, that is comprehension part. So even if you will repeat the question will not make any sense to the person. I mean, you're not asking some very difficult theory of physics. You're simply asking the person, okay, tell me your favorite food item. And the person is not gonna understand the problem or is not gonna understand the query that you've raised. So understanding is a function of Wernicke's area. So if Wernicke's area is damaged, that would be due to blockage of the inferior division of the left middle cerebral artery, because mostly it's the dominant part of the brain related to speech. And therefore, in this chap, please remember Wernicke's area damage, fluency will still be preserved. Remember, I told you fluency is a function of Broca's area, no? So the person can keep on talking whatever he feels like. He can use words like dog, chicken, Pakistan. Now you are a person who loves India, so you can maybe correlate dog and Pakistan, right, as one, but this chap has no correlations. So he's just using random terms like dog, chicken, Pakistan, Zika virus, something like that, coronavirus. So jargon speech is a feature of Wernicke's area damage. And the connection between the Broca's area and the Wernicke's area is referred to as arcus fasciculus. And I hope you remember the fact that arcus fasciculus is the one which is responsible for repetition. So this will help you solve another question of the exam, that person can understand everything but cannot repeat. Understanding is a function of Wernicke's area but cannot repeat. Where is the lesion located? Your answer is arcus fasciculus. This helps you in repetition. Like suppose I say, okay doctor, you learned these facts, can you just quickly repeat them before me? So you can listen to me, understand, and then speak it out. But in this chap, where arcus fasciculus is affected, the person will definitely be able to understand what you are providing. He might nod his head because he can see, he can hear, but then ability to repeat will definitely be lost in a person if the lesion lies in arcus fasciculus. The minimum that I expect you to remember at this junction are the following terminologies. One is this term, that is anomic aphasia. That's what they love to ask. And this is usually a feature of metabolic encephalopathy. So when you will read about ammonia intoxication in the topic of fulminant hepatic failure, that's where this term would come into picture. Then usually they ask about expressive dysphasia. or instead of talking about expressive, because that will make it obvious for you, lots of time he might just use an alternative terminology. So the usual terminology that you will notice will be saying motor aphasia, because we can treat this as an area which is responsible for expression. Expression is like you are vocalizing, so that vocalization part is affected, hampered, because Broca's area is gone. The blood supply that would be going in this case would be the superior division of the left MCA. LMCA stands for left middle cerebral artery. It's the M4 segment of it that would be compromised in the person. And another term that I want you to remember is receptive dysphasia. Lots of time the alternative term that is used for this might be jargon speech, because he's randomly speaking whatever that is coming to his mind. In fact, people with jargon speech can be misdiagnosed as having schizophrenia, because schizophrenia people might even keep on talking like anything, but then schizophrenia people, what they talk about is that they can see people. He will say that he can see his grandfather who died 20 years ago and stuff like that. So, I mean, you definitely can pick up a schizo versus a person of jargon speech. This would be a feature that would be seen due to involvement of the inferior division, which would be supplying the Wernicke's area of the left MCA, M4 segment. These are standard easy pickups that you have to remember for the exam. Coming to the next question, he is talking about a person who's on a follow-up for recurrent abdominal pain. The ultrasound of this guy has revealed a pretty big 40 millimeter, 4 centimeter aortic aneurysm. What should be the next immediate step? Well, one, all of you are aware of the fact that the lesion responsible for aortic aneurysm is atherosclerosis. You are also familiar with the fact, and I've mentioned that in the routine cardiology discussion, that if a abdominal aorta aneurysm, that's the commonest side, is more than 5.5 centimeter, the chances of spontaneous rupture are substantially high. So one of the indications for surgery in any person who's having a abdominal aorta aneurysm would be, if it is more than 5.5, spontaneous rupture is definitely a risk, so repair should be done. In this particular question, I can say that wait and watch looks like an extremely conservative approach, considering the fact that person is having symptoms. I'm ruling out option number D in this question. I'm going from reverse because it is written immediate surgery. So I need to be very concerned about the fact that should I answer conservative, should I answer surgery? I am planning not to go for conservative mode in this guy. Why? Because of the fact that if this guy was asymptomatic and the size of the aneurysm was 40 mm, it's okay. I mean, I can monitor the patient subsequently. But since he's symptomatic, I'm worried this could be a possible impending rupture developing in the person also. He's having recurrent abdominal pain. The severity is increasing on a regular basis. Wait and watch is not the answer to this question. Why? Because the person is symptomatic and the size of aneurysm is pretty coming close to that danger level of 5.5 centimeter. Medical therapy with beta blockers. Well, I'll just show a snapshot from Harrison that is said that what you can do to reduce the progression of abdominal aorta aneurysm is not beta blockers. What will you give? You will give statins. Why? Because the problem is atherosclerosis. So it is statins that will reduce the progression of the atherosclerotic lesion. So the weakening of blood vessel will be lesser and the aneurysm progression will also be lesser. Beta blockers have not been shown. I'll just show you this image. He has highlighted the statement. I'll just underline it before you. Medical therapies like beta blockers and RAS inhibitors have not proven effective in reducing the rate of aneurysm growth. This is a direct snapshot from Harrison that I've shown before you. Beta blockers do not have any role. Beta blockers are good for chronic stable angina. They are good for conserving oxygen in the heart. Beta blockers can be used in chronic congestive heart failure, but beta blockers do not play a role in management of abdominal aorta aneurysm, and that is why he has talked about mainly use of statins. So answer to this question definitely cannot be option number C. Observe till it reaches 70 mm and then do surgery. I mean, that's an outrageously wrong statement, because if I said cutoff is 5.5, then option number B does not make any sense. That leaves us with A as an answer. The bottom line to understanding this question is that we intervene if the size is more than 5.5, or we intervene when the person is symptomatic and the size is pretty close to the upper limit of where it can rupture spontaneously. So again, a surgical management of the person is recommended. I'll also show you an image from the surgical textbook just to validate my statements. What are the indications for surgery in case of abdominal aorta aneurysm? I'm just writing out triple A, abdominal aorta aneurysm, asymptomatic aneurysm more than 5.5 centimeter. On monitoring, if the rate of growth is more than 0.5 centimeter per year, then is a painful tender aneurysm. Now this chap, he's having history of recurrent abdominal pain, so there's a possibility now that last time you discharged him because it was maybe 3.5 centimeter and he was having tummy pain, you managed him conservatively, but now the pain has increased in severity and the repeat scans are showing a size which is 4 centimeter. So it has upgraded by zero point 0.5 centimeter as compared to, let me say, 6 months back, and the symptoms also have become more prominent. Then definitely a cause of concern and intervention in the person should be done. The fourth indication is a thrombosed aneurysm, or inside the aneurysm there could be formation of emboli. I mean, there could be clots developing in the aneurysm because there's stasis, right? There's an aneurysm, so there's a stasis relatively present, and therefore there could be clot formation, and these clots can embolize to distal circulation. So the clots can definitely move on to the toes, they can go on to the fingertips, and you might even have is gangrene developing in these patients if interventions are not done. So these are the indications for surgery. I repeat that again: 5.5 centimeter or more without symptoms. If it's symptomatic, definitely go in for intervention. Size increasing by more than 0.5 centimeter per year. And if it is extremely painful right now, or the severity of pain is on an incremental mode, you need to intervene in abdominal aorta aneurysm. The answer to this question is A. Both in NEET 2019 and 2020, they've asked about abdominal aorta aneurysm. So definitely a topic to be read from both Bailey and the aspects that I am saying. Coming to the next question, he's talking about a person who's undergone a bilateral adrenalectomy in view of a bilateral pheochromocytoma. Now that would be pretty a nasty situation because traditionally pheochromocytoma will be unilateral, but here still bilateral, that's a rare aspect. Post-operatively, the patient is having lethargy, fatigue, and loss of appetite. That definitely tells about adrenal hormone deficiency. The BP is on the lower side. That further potentiates the fact that both the production of aldosterone and cortisol have suddenly reduced. Aldosterone, cortisol play an important role, mainly aldosterone, but even cortisol plays a role in maintenance of blood pressure. And in this particular case, since these hormonal deficiencies are present, so the correct answer to this question would be option number C. When I talk about it, a lot of chaps, they put up this query that is blood pressure maintained by cortisol, because cortisol is basically the stress hormone in the body. The main function of cortisol is maintenance of sugar values. Now look at what I say for glucocorticoid. GC means glucocorticoid. We're talking about cortisol. Please remember that glucocorticoids help in maintaining vascular response to angiotensin 2. So I can put it like this, that glucocorticoids, they potentiate the effect of angiotensin 2, and angiotensin 2 when it acts on receptors causes vasoconstriction. So does norepinephrine, so does renin. So I basically want you to understand that glucocorticoids potentiate the vascular response to all these, and they helps in vasoconstriction. Second, glucocorticoids, they also contribute to decreased production of prostacyclins. Prostacyclin, as you are all aware, is a vasodilator. Now, when glucocorticoids become relatively lesser, then two things will happen. The vascular response to angiotensin 2 will become less and prostacyclin production will increase. Prostacyclin, as I explained to you, is a vasodilator. So the combination of the two things, I repeat that again, what does glucocorticoid does? It increases the vascular response to angiotensin 2, it decreases the production of prostacyclins. But if there's a glucocorticoid deficiency, then reverse will happen. The vascular response to angiotensin 2 will become lesser and the prostaglandin production will increase. The vasodilatory activity of this molecule will contribute to the hypotension component. So both aldosterone and cortisol, and that is the reason why for management of this condition you will require hydrocortisone as well as fludrocortisone. Hydrocortisone is anyway required because in all endocrine emergencies we give hydrocortisone. But fludrocortisone is specifically required in this person, mainly for maintenance of blood pressure also. The remaining options can be ruled out because cardiogenic shock is usually seen with conditions like MI or myocarditis, not present here. Hypovolemic shock would be fluid loss. He himself mentioned there is no evidence of loss of volume. In septic shock, well, there should be post-operative infection developing in a person. There should be at least some evidence, no, of at least fever occurring in a person. We could talk about a surgical site infection. We could talk about a post-operative infection, an intra-abdominal abscess, for example. But that should talk about spiking fever in this chap, which is not given in this question. So I think this was relatively an easy pick. The answer is hormonal deficiency due to bilateral adrenalectomy occurring in this person. Normally, we will not allow this to happen by giving intraoperative, preoperative hydrocortisone to the person. In fact, a hydrocortisone drip can be given during bilateral adrenalectomy to maintain the values of aldosterone cortisol so that at least blood pressure can remain stabilized. But unfortunately, in this case, after maybe hydrocortisone drip was discontinued and the nurse forgot to give a shot of hydrocortisone as you had prescribed, there's a hypotension occurring in this person. So that definitely can be managed with hydrocortisone and fludrocortisone combination. Coming to the next question, he talks about after renal transplantation, what is the commonest opportunistic infection? This is a repeat from 2019 and 18 as well. Well, after renal transplantation, ideally the question should be asked on a time frame basis. Now, when I queried to my students, none of them told about any time frame. So I'll just make you revise the time frames and then we will come to the answer. Suppose a person underwent a kidney transplantation in the month of May 2020, and in June or maybe the end of the June he's having an opportunistic infection because you anyway putting the person on immunosuppressive drugs. So in the first month after a kidney transplantation, there is surgical site infection occurring in a patient. I repeat the statement once again. Post kidney transplantation, opportunistic infections is what we are talking about. Since the person is on immunosuppressive therapy, because I want to minimize the chances of rejection, both acute and chronic, surgical site infections can occur due to negligence of surgeon, but immunosuppressive medication can also contribute to infections even from fungus. This could be ranging from something as simple as herpes zoster or herpes simplex. It could be reactivations of these viruses that could occur due to immunosuppressive drugs being used. But if we are talking about a patient between 1 to 6 months of surgery, then one of the important infections is pneumocystis jirovecii. Yes, the same one that causes opportunistic infection in AIDS positive patients with CD4 count of less than 200. The same organism can cause trouble here because you are anyway putting the patient on steroids. Now we come to the important one, cytomegalovirus. I mean, they usually ask very commonly about it. Cytomegalovirus can contribute to graft failure. Graft failure after bone marrow transplantation, graft failure after solid organ transplantation is mainly attributed to this virus. Whereas if we talk about after 6 months, then one of the important viruses that is to be remembered by you is polyoma virus, which can also be written as BK virus. Prior to this, even aspergillus can be written. Do remember the fact that this list which is given in Harrison has been extensively asked in the exam. Overall, the commonest one out of these is cytomegalovirus, and that happens to be the answer for this question. They had asked this question in a different way, so I'll just verbally say that question to you. The question said that a patient has undergone a kidney transplantation, but then there's a graft failure. He first described transplantation, then he explained that there is a graft malfunction, like the urine output of this person has not picked up like it should. The urea creatinine values are not coming down as they normally should have. So, because there's a graft malfunction, the doctor decided to get the urine of this patient tested. And in the urine microscope examination, he mentioned that multiple renal tubular cells were seen. Like these cells are sloughing off, the tubular lining is getting damaged by infection, so renal tubular cells were sloughing off, and he gave an image in which there was basophilic, mark my words, basophilic inclusions inside the nucleus of this renal tubular cell. And that again tells you that we are talking about cytomegalovirus. We need to start gancyclovir in the patient, but he just tried to make a question longer. The keywords were graft failure and owl eye appearance in the image of basophilic inclusions, which are intranuclear inclusions that are to be remembered by you for especially post kidney transplantation. And the same answer is also for bone marrow transplantation. Though I can mention a related question also. Virus which is responsible for post transplantation lymphoma. Now, the moment you read post-transplantation lymphoma, what should click in your mind is definitely not cytomegalovirus. Then it would be Epstein-Barr virus. So do remember this related question also. The common virus that complicates a solid organ transplantation or bone marrow transplantation happens to be cytomegalovirus, but the transplantation lymphoma of that develops is Epstein-Barr virus. Answer to 14 is Bombay. Coming to question number 15, he's talking about a person who's 29 years of age brought to the emergency department with nausea, vomiting, abdominal cramps after eating meat in a dinner. What is the likely cause? I mean, this question is repeated up to number of times. If between 1 to 6 hours of food intake there is a food poisoning occurring, that is mainly due to the preformed toxin of Staphylococcus aureus. So answer to 15 is Bombay. So whenever he gives you, and most of the time he has given regarding potato salad, or it could be cold cut meats which have not been preserved at right temperature and then they have been reheated in the microwave. So potato salad, cold cut meat, salads, they are the ones which are usually incriminated in contributing to staph aureus related food poisoning. The manifestations will occur within 1 to 6 hours of intake of food. Coming to the next one, he talks about first line drug for postmenopausal osteoporosis. You are familiar with the fact that the definition of osteoporosis would be based on the values of the T score and the Z score, and mainly we take into consideration the T score. The value T score less than minus 2.5 standard deviation. What we are doing here is simply evaluating the bone densitometry. So the T score would be calculated at the following areas, that is mainly at the femoral neck. As you are all aware, like an old woman, she falls in the bathroom, she could fracture femoral neck and then avascular necrosis can develop, and this fracture of the femoral neck would be mainly secondary to the osteoporosis, the weakening. Then could be stress fractures in the vertebra. So the bone densitometry test will be checking for the bone density at the following sites, that is femoral neck, lumbar spine or total hip. If the values at these areas aggregate is less than minus 2.5 standard deviation, that's definitely a patient who's having osteoporosis. If he writes in the question T score as well as Z score and then says the fact that which of the two is used for treatment, then the guide to treatment is T score. Remember, treatment begins with T and T score also begins with T. So the T score is the guide to treatment. That's the one that is mainly to be considered. Now, if a person is a high risk patient would imply that there has been luckily no fractures till now. And a very high risk patient, then the drugs that we use for the person will change slightly. Very high risk patient means that already past history of a fracture is present. Like this old woman, she fell in the bathroom and there's a fracture of the femoral neck. Past history of a fracture is present. So for high risk patients, the main answer would be bisphosphonates. We can be using molecules like alendronate, risedronate, or zoledronate. In fact, zoledronate needs to be given once a year infusion. It just takes 15 minutes, because you see, when you write risedronate once a week or alendronate every day, because of the side effects of these drugs, a lot of these old women, they will stop taking this drug. So most of the time, the molecule that is recommended, like if you are prescribing it once a week also, you will tell the person not to lie down after taking this tablet because they could be reflux esophagitis. So risedronate is the one that is usually prescribed. Or you can be prescribing molecules like that I'm writing subsequently before you, that would be denosumab. But when it comes to very high risk patient who's already sustained a fracture, then they've recommended use of teriparatide. Teriparatide would be artificial PTH. There is a variant of it which is now available, so I'll just mention the new one here, that is abaloparatide. You just need to get the names right. The bottom line is that bisphosphonates are the first line for routine cases of osteoporosis. But if it is a very high risk patient, in those circumstances, that's a person already sustained a fracture once, to improve the bone density, we can be using in the patient abaloparatide, and denosumab is the common between both of them. Now, when it comes to our question, from this information, you can deduce the answer. The question simply said, what is the first line drug? The answer would be given as bisphosphonates. That definitely improve the bone density of the person. In fact, if you know a patient of yours who is old age and is having osteoporosis documented by bone densitometry, I would suggest you to prescribe to this person zoledronate infusion. It will take only 15 minutes. It is once a year. And obviously, because the medicine is once a year, the compliance part will definitely go up, and the chances of sustaining a fall and then a fracture would substantially be reduced. Falling can still occur because the old age, you see the body is stiffer, muscles are wasted, so fall can occur, but sustaining or being able to handle that fall is what matters. So if an old man or a woman they fall and then they sustain a fracture, that's definitely a problematic aspect that is to be remembered by you. I'll just show you the reference for this. This is 2020 guidelines for management of postmenopausal osteoporosis, as you can see on the screen. And he has mentioned that for high risk patients, what is recommended first line is bisphosphonates only. I'll just zoom it in so that you can just see the names. That is alendronate, risedronate, zoledronate. Any of these can be given. I said obviously cost will matter because alendronate is expensive as compared to risedronate. And denosumab is included in both of them, that is risky and very high risk patients. So that's the endocrine guidelines, guys, for postmenopausal osteoporosis that I have just shown as a slide before you, because there was a bit of controversy regarding use of raloxifene. So raloxifene can be used in later stages. You see, you are all aware, bisphosphonates after a certain amount of time, mostly after 3 to 4 years, we don't give bisphosphonates. In fact, if you are giving bisphosphonates for, let me say, 5 consecutive years, there's a possibility that person might develop pathological fracture. And there has been a question in the AIMS exam in the previous years where he has mentioned that a lady is on alendronate for past 5 years, and now she came to the hospital with limping. Why? Because she is having a pathological fracture of her femur due to indiscriminate use of bisphosphonates. So bisphosphonates are to be used for a safe period of 3 years, then a drug holiday. Don't give bisphosphonates in that drug holiday period. What will you give? You can give calcitonin nasal spray because that has a very good analgesic effect. And along with that, at that point of time in a postmenopausal lady, is because you have introduced a drug holiday from bisphosphonates, what you can introduce is raloxifene. So that's the time when it can be introduced. Along with this, vitamin D and calcium is anyway to be taken. Vitamin K is what, that was again a question. Which vitamin is useful for osteoporosis patients over and above vitamin D supplementation? That would be vitamin K. That has been shown to improve the bone remodeling component. So answer to the question that was raised as first line drug for postmenopausal osteoporosis is bisphosphonates. Coming to the next question, he is talking about a patient with a water hammer pulse. Before I come to the answer, I'll just show you an image here. This image was not in the exam. This is only for representational purposes. I would be first checking the pulse of this person using a 2 finger or a 3 finger technique. Then I will ask the patient, is there any problem with the shoulder joint? When he says a no, I will suddenly raise his arm above the level of the head. You see, the doctor here is feeling the radial artery of the patient under her fingers. When she will suddenly raise the arm of the patient above the level of the head, the blood will race back towards the heart. In you and me, the blood will never get access into the cavity, but in this case, you can see that I am showing that the cavity of the heart will get distended because there's an incompetent aortic valve. So if the blood will go back in the heart, see what it will do. It will increase the end diastolic volume, and if end diastolic volume is increased, then it will increase the power of contraction also. You are aware from physiology regarding what is called as Frank-Starling law. If you stretch the heart, it contracts with more force, and this force will contribute to the next impulse coming in the patient. This doctor will compare the initial impulse when the arm was at the level of the head with the impulse that will come now on sudden elevation of the arm. The impulse will come more forceful than what it originally was. So this kind of a pulse that you can feel is more powerful than what it originally was on sudden raising of the arm of the patient above the level of the head is called as water hammer pulse. It's also referred to as collapsing pulse because the next impulse will be more forceful, but then the impulse will go away fast also. You will feel a sudden tap under your fingers. That sudden tap under your fingers is the forceful impulse of ejection. Force or the power being generated by the heart has increased. So there are two things that I said. One, the force of contraction increases, but that is not a sustained effort. Why not a sustained effort? Because the blood again leaks back into the chamber of the heart, which does not happen in you and me. I will put it like this: 0 ml of blood leaks between the valve leaflets in you and me. usually because our valve leaflets are competent. But if the aortic valve leaflets are incompetent, that is when this happens. A forceful impulse on sudden elevation of arm over the level of the head, followed by sudden decrease of pressure, and this is definitely a feature of aortic regurgitation. That was pretty a straightforward MCQ. I just tried to give an explanation about why do you have a water hammer pulse. It's also referred to as collapsing pulse, and it is also referred to as Corrigan's pulse. Moving on to the next question. In comparison to a normal healthy person in evening time, which of these patients will be having elevated ACTH as well as elevated cortisol? Now there are two things that he's saying. Both ACTH is elevated as well as cortisol in the person. Let's take up option A that talks about a normal healthy person in the morning. You see, our cortisol values will always be having a diurnal variation. What I mean by diurnal variation is that cortisol values are usually highest in the morning hours when we wake up. I mean, if I just try to sketch it here, I'll put it like this, that the cortisol values of ours keeps on fluctuating. But then the moment we wake up, let me say you wake up at 6 a.m. in the morning, then you start going to your work. So the cortisol values in a normal person will definitely start rising. So in a normal person, cortisol values begin to rise after the person has awakened, and it would be lowest at when the person was sleeping very deeply, maybe in the REM phase of the sleep. So normal person in the morning will be having a elevated cortisol, but ACTH values will be relatively lesser because of the feedback mechanism, because when cortisol will rise, then ACTH will decrease. So A is not the answer. In Addison disease, you would be having rather decrease of all the three hormones, aldosterone, cortisol, as well as sex steroids. And even if I take up the case of a secondary Addison disease here, like Sheehan syndrome, then Sheehan syndrome will cause destruction of the pituitary, and destruction of the pituitary will cause ACTH to decrease, and if ACTH will decrease, then cortisol values will also decrease. Whereas in the question is asked about elevated ACTH and elevated cortisol, so I'm ruling out option B. Why? Because ACTH cortisol both are less in Sheehan, that is secondary Addison disease. Now we come to Cushing disease. You are all aware that Cushing disease is due to a pituitary tumor. That's gonna be a pituitary adenoma. This pituitary adenoma is going to produce one hell amount of ACTH, and that will act on the second layer of adrenal gland to cause more production of cortisol. So both ACTH as well as cortisol are substantially elevated in a person with pituitary adenoma. So this definitely looks like the correct answer. Let's look at D, after exercise. Well, I can put it like this, that cortisol is the stress hormone. So if you do very strenuous exercise, then cortisol will rise. Otherwise, there is normal values only. So I can put it like this, that after exercise, cortisol values may either remain normal or might remain elevated if it is a very strenuous exercise. So the point is, if cortisol will rise, then subsequently the ACTH values of the person will begin to fall. But in this question, he has basically mentioned that which of the following conditions will have elevation of both ACTH as well as cortisol. So the answer to this scenario should be given as Cushing disease. Cushing syndrome occurs due to iatrogenic steroids. It can occur primarily due to person taking this Ayurvedic or homeopathic medicines, and a lot of them contain steroids. So person may not be even aware of the fact that he is taking steroids in this Ayurvedic medicine. So lots of them will deny the fact that when you ask about steroid intake history, they'll deny, they'll say, oh, I take some health supplement. But Cushing disease is a term that is specifically used to explain a pituitary adenoma that is going to produce excess of ACTH and higher values of cortisol. Answer to question number 18 is choice number C. Coming to the next question, he talks about which of the following is not a feature of secondary ACTH deficiency. Now, when I say the word secondary ACTH, that basically means that the pituitary of the person is damaged. The reason why pituitary can be damaged could be due to postpartum hemorrhage. It will cause a pituitary infarction in the person. So the values of ACTH will decrease, and when ACTH will be lesser, then cortisol values will also be substantially reduced. Now listen to the next part very carefully. Though I have highlighted this in the earlier part of this particular discussion, I'll just say this again. One of the effects of cortisol is that it potentiates the effects of angiotensin II. It upgrades. I'll put it like this, instead of just saying the word potentiate, I can say that it will upgrade the effect of angiotensin 2 on its receptor, which will cause vasoconstriction. The basic point is, when it comes to maintenance of blood pressure, aldosterone plays a role. Definitely, yes. But even cortisol plays a role in maintenance of blood pressure. How? By potentiating the effect of angiotensin 2, as well as norepinephrine, as well as renin. The second effect of cortisol is that it decreases the production of prostacyclins. Now, what does prostacyclin do? It causes vasodilation, and vasodilation, if it becomes lesser, so then the blood pressure will rise. This is normal, right? Cortisol potentiates the effect of angiotensin 2 and decreases prostacyclin production. Therefore, vasodilatory activity is less. Now, I'll say opposite of this. Imagine a situation where cortisol is less, then action number one will be lesser, less potentiation of angiotensin 2 and norepinephrine when, and rather now the production of prostaglandin. I'm putting an opposite arrow to say that because cortisol is less, prostacyclin will be produced more, and prostacyclin will cause vasodilation, and because there is a vasodilation, the BP will begin to fall. So cortisol deficiency contributes to hypotension. This is a correct statement. Most of the guys, their query was, do you have hypotension with cortisol deficiency? I provided two reasons. I'll state them again. Cortisol potentiates the effect of angiotensin 2, that potentiation will be less. Cortisol decreases the production of prostacyclin production. Now the production of prostacyclin will be normal or increased because there is no check, and because it is normal to increase and there is no check, so therefore vasodilatory activity will occur that will contribute to hypotension. Fatigue is definitely a feature with the ACTH because hypoglycemia component will come in. You don't eat the whole day, you feel so tired. So fatigue and anorexia are definitely manifestations given, but when it comes to hyperpigmentation, the explanation is that ACTH has a partial MSH activity also. In any condition where ACTH will become very high, like suppose we say a person is having lung cancer is producing ACTH in excess amount. So because ACTH has a partial MSH like activity, the disadvantage will be that this partial MSH activity will cause hyperpigmentation. This hyperpigmentation appears where? In palms and sole creases. It could occur in the cubital fossa, in the axilla, groin of the person, areas around the genitals. It could even occur in the areola, previous surgical scars, or even in the mouth, inside of the mouth, mucosal melanosis. So the bottom line is that ACTH produces MSH-like activity, can cause hyperpigmentation. If ACTH will become less in secondary ACTH deficiency due to Sheehan syndrome. In fact, I can just write the word here Sheehan so that you can relate to everything better. You see, this lady had a delivery, and after that, all the six hormones of the anterior pituitary supply is gone. Because of postpartum hemorrhage, she had an anterior pituitary infarction. So Sheehan syndrome can result in development of secondary Addison or secondary ACTH deficiency, and therefore the manifestation in the person would be deficiency of cortisol. And once the cortisol deficiency occurs in this person, the BP would become lesser, and rather the hyperpigmentation part will be replaced by a pale skin. There would be a pale skin in the person of ACTH deficiency. So let us also revise conditions where I have explained to you hyperpigmentation that will occur in palmar and sole creases. The mnemonic for that is CAN, where alphabet C would stand for Cushing disease. You are familiar with the fact that in Cushing disease, there would be more ACTH due to pituitary adenoma, and more ACTH will contribute to hyperpigmentation. A would stand for Addison disease of the primary variety. So I'm just putting a prefix here. The primary Addison disease could occur due to autoimmunity. Alphabet N would occur as Nelson syndrome, that is a complication after bilateral adrenalectomy. So these are the situations that I've described where you get hyperpigmentation of palmar creases, sole creases, but you do not get it in secondary Addison because ACTH is less. Answer to 19 is C. Coming to the next question, he talks about this young lady, 26 years of age. She has developed after her delivery features of headache, nausea, and visual complaints. Well, when you read about headache, nausea, and visual complaints, you have to think in terms of possibility of her having a CNS event. And what is the CNS event that can contribute to these manifestations is by the name of pituitary apoplexy. There could be bleeding in the pituitary, and that can contribute to even third nerve palsy, because the area where the pituitary is, if the bleed occurs, there could be pressure on the optic chiasma, or the oculomotor nerve is going through that area, so that could would get involved or affected, and that can explain the visual complaints of this person. And the headache and nausea component can be explained by raised ICT because there is a CNS bleed in the person. Apoplexy means CNS bleed. So therefore, the correct answer for this would be that the pituitary is gone, and therefore there would be hormonal manifestations of Sheehan syndrome developing in the person. Well, hyperprolactinemia is rolled out immediately because hyperprolactinemia will present with galactorrhea. Waterhouse-Fridson syndrome is common with meningococcemia, so that will rather present with petechiae. It will present with hypotension and then maybe stupor and altered sensorium in the person. When it comes to D, pituitary adenoma, then pituitary adenoma can be producing multiple hormones. But then pituitary adenoma per se is not going to contribute headache, nausea, and fatigue. Visual complaints can be there because you see pituitary adenoma, when it will become bigger, it can contribute to bitemporal hemianopia. It can press on the optic chiasma and bitemporal hemianopia can be present. But then when it comes to headache, nausea, that is features of raised ICT, that is unlikely to be seen with pituitary adenoma most of the time because most of these are microadenomas. Even if they become macroadenomas, to have raised ICT is little less common. And then he has also given the clinical scenario after delivery. So a more comfortable answer for this question would be Sheehan syndrome, where all these manifestations can be explained relatively better. Though a close answer to this can be pituitary adenoma also, especially a macroadenoma can contribute to raise ICT. So if I compare B versus D, considering the circumstantial evidence of her presenting mainly after delivery, if this was not given, I mean, even option number D had a strong chance of being the correct answer. But as I explained to you that the circumstantial evidence of delivery onwards has contributed to this manifestation, so we have to think in terms of a possible pituitary apoplexy. And yes, it could be a possibility she had a pituitary adenoma and it bled at the time of the delivery. Or it's not necessary, it could be possibility that during a pregnancy she had hypertension. Hypertension can also contribute to pituitary apoplexy. So the circumstantial evidence of the question is more in favor of Sheehan syndrome as compared to that of a pituitary adenoma. That was a fairly, I would say, a intelligently created options there. Answer to 20th is beta. Coming to the next question, we are talking about a patient of scleroderma who's having acute respiratory distress. The X-ray shows bilateral reticular basilar shadows. What would be the next investigation? You are aware of the fact that scleroderma per se will contribute to interstitial lung disease. The name itself is there. No, sclerosis means fibrosis, so there would be lung fibrosis, interstitial lung disease. That would contribute to hypoxia, and hypoxia will cause pulmonary artery hypertension. Pulmonary artery hypertension will cause cor pulmonale and will cause right ventricular failure. The clinical features of right ventricular failure can be in the form of congested neck veins, hepatomegaly, or pedal edema, and none of them are given in this question. He is mainly focusing only on respiratory distress, but there is no pedal edema, no hepatomegaly, no ascites, no congested neck veins. So option A, echocardiography to look for cor pulmonale. Yes, I will do a echo in this person, but not right now. He's talking about next line of investigation. No? So we have to answer single best investigation. Because in this question features of pulmonary artery hypertension like loud P2 or right ventricular decompensation are not given, this may or may not be the answer to the question, so I've just put a plus minus in front of it. High resolution CT scan is option B. The advantage of HRCT always is that it tells you about parenchymal involvement. So in this disease, the parenchymal involvement is mainly that of NSIP. As you're aware, NSIP is a histopathological term that is non-specific interstitial pneumonitis. The more it is, by plus sign I mean, the more it is, more will be the chances this person dying. I mean, the prognosis of a person of scleroderma is dependent on a HRCT chest because that will tell you regarding whether this person can die because of it. Because one of the important causes of lung transplantation, as you are aware, is pulmonary fibrosis. In scleroderma, there is an autoimmune cause, so CT will rather reduce the requirement for going for a lung biopsy. You see, lung biopsy is definitely an invasive procedure. If we can demonstrate on a CT scan that there is a substantial parenchymal involvement of the person, then there is no need for lung biopsy in the patient. So what are the advantages of a CT scan? It definitely tells you about the extent of the disease. It tells me about the extent of the disease. and it also decreases the requirement of me going for a lung biopsy of the patient. So this again can be answer for this question. So I'm putting just a single plus sign in this question. There's no negative for it because as such I said core pulmonary features are not given in the question. So I've just put a plus sign to say this may be the answer. Pulmonary function testing. I'm ruling that out. Why? Because pulmonary function testing is dependent on the skill of the operator. You see, if you don't give commands properly of inspiration, expiration, a patient may not, due to language issues or your explanation may not be correct. I mean, however good a doctor you are, your communication skills with a patient may not be so good that to a less educated person you can tell what is inspiration, what is expiration, when to hold breath. So pulmonary function tests are subject to lot of bias. I'm ruling out option number C here because PFT can never confirm obstructive. It can obviously tell obstructive restrictive pattern, but you cannot confirm obstructive and restrictive only by spirometry because it is dependent on the cooperation of the patient. So I would like to rely on technology. I would not like to rely on the skill of the operator and the compliance of the patient. So I'm ruling out C. When it comes to contrast enhanced CT scan, you see, we are not talking about any vascular disease related to the lung. We are simply talking about parenchymal involvement. And for parenchymal involvement, we mainly go for HRCT. So we have to select between echo and a HRCT. For echo, the negative point, I mean, why it should not be the answer is that, well, there is no features of right ventricular failure given in the question. And anyway, that will occur very late. At the moment, I have just identified a person of scleroderma with currently respiratory distress. So if somebody is having distress, I want to see how much percentage of lung is involved. What is the status of the upper lobe versus the middle lobe versus the lower lobe. So because my requirement is the way I mentioned to see for what is the percentage of lung involvement, the best answer for this question would be option number Bombay, that is a high resolution CT scan. To supplement this, I will be showing a snapshot from Harrison to you so that you can appreciate this better. Let us see what Harrison says. He says chest radiography or X-ray can be used as an initial screening tool, but it is insensitive for detection of early interstitial lung disease and our patient is having disproportionate respiratory distress. So if I want to do a chest X-ray, it might show some subpleural reticular linear opacities, but then just seeing those opacities will not tell you whether there is a substantial lung fibrosis present in the patient, whether there's a traction bronchiectasis in the patient. So he says subsequently, the extent of interstitial lung disease on chest HRCT is a predictor of ILD progression and mortality in scleroderma patients. Because this person is having respiratory distress, I need to tell the patient what is the percentage of your lungs getting involved with the disease, because ho sakta hai ki this lady has never taken proper treatment. And it's mostly a she only. Scleroderma is a connective tissue disorder mainly found in patients who are females. So the correct answer to question number 21 is Bombay. High resolution CT scan. I highlight why is the answer. I want to know what is the percentage of lung involvement that is contributing to such severe acute respiratory distress. And second, this will also, if I am able to demonstrate the pulmonary fibrosis component, then it will reduce the requirement for doing a lung biopsy in the patient anyway. So option number B is the correct answer for this question. The next question says, a frostbite patient is rewarmed at what temperature? Well, this question would have been discussed by the surgeon as well. So you can imagine a soldier who's at Siachen Glacier. And in fact, I would say questions related to armed forces have been asked in our exam. I will discuss a question subsequently with you for high altitude pulmonary edema that came in the exam. So definitely, I mean, these are a couple of topics which should be known to you. You see at Siachen Glacier, the gloves of the soldier will definitely protect him, but if the temperature is -40, even gloves might fail. I mean, there are instances when the finger will stick to the trigger of the gun. Why? Because it's so cold. You touch cold metal at -40, -50, the finger can stick to the trigger. And due to extreme cold exposure during climbing activity, there's a possibility that a soldier might actually get development of frostbite. So I'm just making it clinically oriented. A soldier at Siachen Glacier, you are the medical officer attached to the unit, and he has reported numbness of his fingers, and there's definitely mottling of the skin or whiteness of the skin. Pain has not started, but he's complaining of that he cannot feel his thumb or he cannot feel his index finger following a climb of few hundred meters that they had to do to maybe provide cover fire for one of the team members or any operational aspects. Now, in a soldier who's having a frostbite, what are you gonna do? You are gonna put the hand or the foot of the soldier or any affected body part into a whirlpool, not a stationary water, but they say whirlpool of bath of water, and the temperature of the water should be ideally monitored to be between 37 to 39 degrees Celsius. If it is not possible to use a thermometer, you can obviously use the backside of your hand and check that it should be adequately warm but not hot. Now, the answer to this question is definitely alpha, that is at body temperature only. 37 degrees Celsius is the temperature at which the rewarming should be done. Hot water is definitely not recommended, or burning water, that might complicate things. Now, because they've asked about this, my question for you guys is, if you're listening to me carefully here, is that suppose a soldier has developed this frostbite in his fingers and he's brought to you right now. You are the medical officer on duty. So, for how long will you keep the hand of the soldier? Because after a while, it will start hurting. Reperfusion, there's a lot of pain, right? So, you need to give analgesics. So, I mean, what is the duration at which you will put the hand or the foot of the soldier in water? I mean, till how long would you do that? So for routine cases, it is recommended about 20 to 40 minutes. That's the duration in which the hand or the foot of the soldier should be put in this water bath at 37 to 39 degrees Celsius. If it's a deep injury, maybe for 1 hour also. What are the guidelines that the person is improving? You will notice that you, after 20 to 40 minutes of doing this activity, the extremity will change color. Earlier it was maybe white, stiff, hard. Now it will soften. So the extremity is flushed, and it will also become relatively soft because the freezing of the tissues that has occurred, that will begin to resolve. But at this particular point of time, lots of time pain starts occurring. So analgesia should be given. One of the commonest reasons why the soldier will take his hand out of water, premature termination of this rewarming, will be mainly because of the pain component. This is mainly related to reperfusion that will contribute to the manifestations. So you will obviously have to use painkillers there. You can give an injection also. The injection can be of diclofenac sodium or tramadol. Any good analgesic would do. You will also notice that now blisters will start appearing, and if the blister is kept like this, it can even turn hemorrhagic. So blisters are developing over a joint. Over a joint, if a blister is developing, you might even have to do aspiration. I repeat the statement once again. After rewarming, the pain will start developing in the thumb or index finger of the soldier or in the toes. So he will try to take his foot out because it will hurt. So you have to give analgesia before the pain starts developing. And blisters, if they start developing, you might have to do aspiration also. Topical application of aloe vera can also help. And what they have documented now is that we can go for intra-arterial, mark my words there, intra-arterial, or if not available, facility not available, intravenous thrombolysis. If we will be using drugs like TPA, tissue plasminogen activator, or retaplase intra-arterially or intravenously, along with low molecular weight heparin, we can definitely reduce the requirement of amputation. Another drug that is recommended for management of frostbite is iloprost. This is also used in pulmonary artery hypertension. Iloprost is the inhaled prostaglandin. It causes dilatation of the blood vessels. So iloprost and thrombolysis are recommended in these patients. And if the strategy is followed, then for severe frostbite issues, you can decrease the amputation chances. Also remember that surgery for frostbite should not be done immediately. You need to allow the line of demarcation to appear. So if a soldier will develop severe frostbite today, like he was buried under ice, there was an avalanche and he was buried under ice for a substantially long duration and his fingers and toes are totally mottled, then he might require an amputation. The amputation should be done at least after 2 to 3 weeks when a clear line of demarcation will appear in this person. I mean, he might lose his hand, maybe both hands, maybe tetra amputation would be required in this soldier. If you want to decrease the requirement and increase the viability of the tissues, get the blood supply to this area. And blood supply would be definitely with thrombolysis plus heparin and iloprost if available. Iloprost is usually not available in India or expensive. I mean, corporate hospitals only at a high altitude at Siachen. Maybe the doctor on duty may not have access. So let's repeat the steps for frostbite. Put the hand in whirlpool bath 37 to 39. Monitor with a thermometer. Give a painkiller shot. Blisters will appear. Pain will appear. Apply topical aloe vera and preferably do a thrombolysis because the thrombolysis has side effects also. It can cause brain hemorrhage, so you need to be aware of the side effects also. So do thrombolysis with low molecular weight heparin. And I mean, depending on the availability, you don't have a thrombolytic drug, you can at least avail heparin, so that at least the blood supply to this area is restored. Maximum what we can do is reduce the requirement of amputation. Otherwise, I mean, this is a bad prognosis. Answer to 22 is alpha. Coming to the next question, it talks about what is not to be done. These are words which are usually neglected by us. He says which is not to be done in high altitude sickness. Well, you are aware of the fact that the high altitude sickness is a spectrum. You could be having high altitude pulmonary edema, you could be having high altitude cerebral edema, or the mildest form of it would be called as simply mountain sickness, where a person will be having recurrent episodes of vomiting. The best management of all of these is one is immediate descent. Now, in armed forces, they may not be in a position to bring down the soldier from a height of, let me say, 18,000 feet because the weather is bad and the helicopter can't land. So they obviously have to manage the patient right then and there. So let us look at how do they manage high altitude pulmonary edema. I mean, immediate descent is obviously recommended, but I said the weather was bad and the helicopter cannot land. So you have to give oxygen to the soldier. This would be about 4 to 6 liters per minute. The objective would be to maintain a SpO2 of at least 90%. We will be giving for management of high altitude pulmonary edema extended release, ER means extended release nifedipine. Please remember these drugs because they have been asked in the exam earlier also and have been taught in the app in high altitude pulmonary edema lecture, but this is a quick revision for you. Now, assuming the fact that the descent could not be arranged even after, let me say, 2-3 hours and the weather is not improving, then you will put this soldier in a gammo bag. The image of gamma bag I've shown in the lecture of high altitude pulmonary edema. You can go there. This is like a bag in which you can give hyperbaric oxygen therapy. It simulates a descent. Other drugs which have been recommended to be useful in high altitude pulmonary edema is salmeterol. Then even tadalafil has been used. This tadalafil is also taught for management of even pulmonary artery hypertension. The same molecule has been used even in management of high altitude pulmonary edema. And then dexamethasone. In fact, dexamethasone has mainly been shown to have a preventive role rather than a therapeutic role. So I'll repeat once again, what are the drugs recommended for high altitude pulmonary edema? Oxygen, nifedipine, hyperbaric oxygen therapy, or gammo bag. I've written the commercial name gammo bag. It basically means simulated descent and a hyperbaric oxygen therapy. Also used are salmeterol, tadalafil, and dexamethasone, with dexamethasone mainly having a preventive role. When it comes to high altitude cerebral edema, again it is immediate descent. If not possible, put the soldier in a gammo bag that will simulate a descent. And the main treatment for high altitude cerebral edema is dexamethasone. Now mark my words there. Dexamethasone was preventive in high altitude pulmonary edema. It was for prevention in high altitude pulmonary edema, and it is therapeutic in high altitude cerebral edema because this is a vasogenic cerebral edema. Along with that, gamma bag will definitely be used. For acute mountain sickness, both for therapeutic and preventive purposes, acetazolamide can be used. Though this is a diuretic, so the person will have to go to the washroom again and again to urinate, and I mean that takes a toll. No? Going to the finding a washroom at a high altitude area is itself a challenge. No? But then at the same time, apart from immediate descent, acetazolamide is one molecule that reduces, I would say, the incidence of the remaining two. So acetazolamide can be used for prophylaxis as well. If you're planning to go for a vacation to high altitude, of assuming the COVID thing is over, and after you cleared this exam, you decided before you dedicate 3 years of your life into a medical college again for 3 years post residency, you decided to go to a trek to, let me say, Ladakh or lake. So when you go to that high altitude area, don't start doing trekking from the first day. Take rest for 1 to 2 days. Let your body settle down to low oxygen environment and take acetazolamide if you plan to go trekking, because this will reduce the severity of your mountain sickness. Otherwise, you will start puking. And if suppose you go up too high in a very short period of time, It might even cause pulmonary edema, it might even cause cerebral edema. It happens to our soldiers at high altitude. They can suffer not only from mountain sickness, in which they'll be puking and they'll not obviously eat food, and without food there's no energy. So obviously a soldier can't be fighting fit. But then high altitude pulmonary edema and cerebral edema is one of the reasons why in the highest battlefield in the world, that is in Siachen Glacier, I mean we lose our soldiers. So the correct answer for this question is beta. Digoxin is useful for heart failure in pediatrics and has no role in management of high altitude sickness. Answer to 23 is Bombay. Remaining choices are fine. Coming to the next question, he says which of the following is not a clinical presentation of pituitary apoplexy? Apoplexy, as you understand, would mean that there would be bleeding in the tissue of the pituitary. That is definitely going to contribute to hormonal deficiency in the patient. If the anterior pituitary blood supply is gone, then the six hormones that are coming from the anterior pituitary will definitely go down. The bleed can definitely extend into the sella area, and that can compromise the cavernous sinus. It could damage the optic chiasma. It can damage the oculomotor nerve. Why would you be having a intrapituitary hemorrhage? There are various reasons for it. One is that the pituitary tumor might become so big that it might actually outgrow its blood supply. I repeat that again. The tumor has become so big that it has outgrown its blood supply. Another can be Sheehan syndrome. You're aware the leading cause of Sheehan would be postpartum hemorrhage that will cause an infarction and even a possible bleeding. Then diabetes mellitus, hypertension, and sickle cell anemia are standard causes for any CNS bleed. I mean, any CNS bleed you read, diabetes, hypertension, sickle cell anemia are already given. The clinical features in these patients will be related to mainly deficiency of ACTH, because the moment ACTH will decrease, there would be a decrease in the values of cortisol in the person. So one of the important features will be that of irritability and mood swings and fatigue and tiredness would be due to deficiency of cortisol, and sugar values will decrease. Cortisol also plays a role in maintenance of blood pressure, so ultimately the BP values would be lesser. So the important thing to be understood is that pituitary apoplexy will contribute to features of adrenal insufficiency. All the six hormones will become lesser. That's not the problem. See, my point is, if TSH will become lesser, then T3, T4 will become lesser. That will contribute to cold intolerance and maybe weight gain. But these findings will take time to appear. I'm talking about what is going to happen immediately in the first few hours after a pituitary hemorrhage, and that is mainly related to decrease of ACTH. Because suppose growth hormone will become less, it is not going to cause great impact. If it's going to be decrease of LH and FSH in a lady, she will develop maybe secondary amenorrhea, but impact will not come immediately. But the hormonal aspect whose impact will be coming immediately after a pituitary apoplexy is ACTH deficiency. So hypotension will definitely occur in a person, hypoglycemia will occur because cortisol is the main hormone that is getting compromised in this case. The usual clinical presentation will be that of headache. That's because any CNS bleeding will cause rhizocity. There's irritation of the dura mater. There is irritation of the nociceptive receptors of the trigeminal nerve. So headache is explained by rhizocity occurring in this patient. The blood can leak into meninges. So though he has not mentioned that in the options, I don't want you to ever miss this question, that if you read about sudden onset like meningeal irritation like nuchal rigidity, it not only can be subrecurrent hemorrhage. The learning is not only can it be subrecurrent hemorrhage, it can be pituitary apoplexy as well. Then can be visual changes. Now, what are the visual changes that will occur? It could be bitemporal hemianopia. Why? Because the optic chiasma is compromised. But if it is the oculomotor nerve that will be compromised in the patient, it will contribute to ophthalmoplegia. The bleed can also involve the anteriorly placed cavernous sinus, and cranial going by the cavernous sinus are 3, 4, 6. Out of 3, 4, and 6, if they ask you to select one, it is mainly the third nerve that is usually involved. And along with this, as I explained, cardiovascular collapse will occur. Why? Because adrenal insufficiency will develop in the patient. This is a secondary adrenal insufficiency. The diagnosis of this condition can be made with help of a CT or a MRI head, because CNS bleed will anyway pick up. So cellular hemorrhage can be demonstrated. There might even be displacement of the pituitary tissue. I mean, the bleed will displace the pituitary tissue. The mainstay of treatment for this condition is glucocorticoids. The reason why I have gone into the details of this topic is to make you aware of the options in this question. You will definitely have a headache in this question. Why? Because as I explained, raise SCP due to CNS bleeding. Hypotension will occur in this patient. Why? Because there will be deficiency of cortisol, and cortisol plays an important role in maintenance of blood pressure. Also, I mean, primary role of cortisol is obviously sugar maintenance. Primary role of cortisol is stress hormone in the body, but potentiates the effect of angiotensin too. So, hypotension is present, and vomiting can be explained again by raised acidity. Please appreciate the fact that hypertension is a risk factor for this question. Hypertension is a risk factor for pituitary apoplexy. Look at the question. I cross-checked with multiple students. The question was not about risk factors. He was talking about clinical presentation of pituitary apoplexy. So please remember my words. The clinical presentation of pituitary apoplexy will mainly be that of hypotension. It will not be hypertension. And why why the hypotension component? Because the ACTH values are significantly getting reduced in the patient. The learning that you have taken from this question is one. I want you to understand that if a question talks about a lady maybe after delivery and there's a headache and nuchal rigidity, yeah, you should consider subarachnoid hemorrhage as a possible question. But then along with that, if he starts talking about visual deficit in the form of bitemporal hemianopia, ophthalmoplegia, and cardiovascular collapse developing in a patient, I mean, when you read about a patient of subarachnoid hemorrhage, I have not described any cardiovascular collapse there. So, I mean, you should be able to keep this in differential diagnosis of headache with meningeal irritation. It's not only subarachnoid hemorrhage but pituitary apoplexy, which is also to be considered. And the presentation of this disease is CV collapse, cardiovascular collapse, because of mainly deficiency of cortisol. And when it comes to presentation of this disease, it is hypotension. The causative factor of this can be hypertension. The answer to this question is option number C. Fairly a well designed question, because if you did not read the word clinical presentation, then you can say no, hypo and hypertension both are there. Hypertension is the cause of it and the manifestation is hypotension. I repeat that again. Hypertension is the cause of it, hypotension is the manifestation of it. So he has asked about manifestation per se. That's why the answer to question number 24 is option number C. Coming to the next question, he is talked about a patient of COPD with acute exacerbation. You are all aware that the acute exacerbation of COPD always causes respiratory acidosis, so the pH will definitely reduce. On examination, the patient is conscious and alert, thankfully. So carbon dioxide narcosis has not occurred substantially. Pulse rate is 110 per minute, bilateral wheeze is present. So this is a COPD patient. He maybe had COVID-19, he had respiratory syncytial virus, or any kind of a trigger of a viral infection, post which he has deteriorated. Now, what will you do for management of this condition? So for acute exacerbation, these are the steps that are taken. One, you will use a tight-fitting face mask. I'll just show an image of that tight-fitting face mask. You can see this large mask that we are using even for COVID-19 pneumonia patients, where the lower border of the mask will be something between the lip and the chin, and the upper border would be a tight-fitting face mask so that there's no gas leak, would be at the bridge of the nose. So I want to use a tight-fitting face mask in this guy to deliver high concentration of oxygen and attain a SpO2 of at least more than 90%. You can see it's hooked onto a ventilator. There's a display panel here that will tell you about the pressures that you're deploying. So one of the steps for management of COPD exacerbation is NIV, that is non-invasive ventilation. Non-invasive ventilation is always used whenever the pH of the patient is between 7.25 to 7.35. Do remember the fact that we need to give hydrocortisone, that is to reduce the airway inflammation in these patients. We will be using beta-2 agonist, that is salbutamol. Nebulization would be given. These are the three steps that we usually use, and because carbon dioxide is rising, we are obviously tempted to go in for ventilator strategy. We feel like we should, after looking to the ABG of this person, it appears as if you should put him on ventilator, but he says that for management of this condition, we allow permissive hypercapnia, that is, we can allow CO2 to rise. When I say the word permissive hypercapnia, it will mean that the PCO2 of the person is definitely more than 45, and because of this, the pH of the patient can be anything between 7.25 to 7.35. If the pH goes less than 7.25, going towards 7.2 and lesser, it's always mechanical ventilation. I need to intubate. But if you can maintain a pH between 7.25 to 7.35, we call it permissive hypercapnia. You are having a respiratory acidosis, but you are letting it be. Why? Because suppose you intubate the person, listen to my words very carefully. If you intubate the person and then hook him to a ventilator and you do the routine ventilation, that is assisted controlled mechanical ventilation. In COPD patients, the airway resistance is increased, so you will require higher pressures to ventilate the person. Not only higher pressures would be required, if you intubate this person and put him on assisted controlled mechanical ventilation, higher volumes of air will also be required to be pushed in the lungs of the person. I repeat that again. If I decide to intubate and put the person on intermittent positive pressure ventilation slash assisted controlled mechanical ventilation, one is obviously the risk of ventilator associated pneumonia in India. Even if you neglect the risk of ventilator associated pneumonia, if you will deploy higher pressure, there is definitely a possibility that pneumothorax can occur. Barotrauma risk is there. And when you will send high volumes of air in the lungs of the patient, high volume, that is a high P being generated, high volumes, it can even contribute to hypotension. I want to tell you the fact that in COPD patients, we usually avoid intubating the patient because one, this is going to happen again and again. Even if you forget the risk of ventilator associated pneumonia, barotrauma risk, hypotension risk is always there because you are putting excessive volumes of air in the lungs, so that will press on the SVC IVC. The pressure on the SVC IVC, because of change of pressures in the chest, would decrease the venous return to the heart, so hypotension can occur. So most of the time we prefer a non-invasive ventilation. Please appreciate that in this case I will give steroids, I will give salbutamol, and I will try permissive hypercapnia. Even if the pH is between 7.25 to 7.35, okay, I am ready to take that side effect of increased carbon dioxide. I don't want to ventilate the person. Why? Because if I do that, there is a high probability that on putting this person on a ventilator, the traditional positive pressure ventilation, the barotrauma component or hypotension component can occur. In this question, the answer is delta. It is written non-invasive ventilation is contraindicated. In fact, one of the number one indication for non-invasive ventilation is what we have just studied: acute exacerbation of a patient of COPD. In fact, with the answer to this question, I would like to dedicate one more slide to this topic. Uh, when do you use non-invasive ventilation? Well, we are using it for the following scenarios. In any person of COPD exacerbation, NIV is always recommended. The target is to keep pH between 7.25 to 7.35 as I highlighted. All patients of COVID-19 pneumonia who are having SARI or severe acute respiratory infection, we can definitely put them on non-invasive ventilation. We try first non-invasive ventilation. Apart from this, even in ARDS, non-invasive ventilation has been used initially with some limited success. Treatment of choice for ARDS is low volume ventilation. Please remember, NIV has been tried in ARDS. That does not mean that it is preferred treatment for ARDS. Preferred treatment for ARDS is intubate the person and put him on low volume ventilation. There are some contraindications to non-invasive ventilation also. The contraindications that I want you to remember is that if a person goes into cardiorespiratory arrest, then because there is no spontaneous breathing activity, NIV will not work and you will have to intubate the person. In any person of cardiorespiratory arrest, we anyway intubate. If person is not in his senses, then do not use non-invasive ventilation because that increases the risk of aspiration. So if he says the word encephalopathy, if he says person is in coma, because whenever you read coma, it means that airway defenses are compromised and there is high risk of aspiration. See, in our question, he was very smart. He said that the patient, he had mentioned patient is conscious and alert. That is the important thing that you have to realize in this question. Because the patient is conscious and alert, that is why you can use non-invasive ventilation. Suppose the COPD was patient suffered carbon dioxide narcosis so bad that he is unresponsive to your commands, then non-invasive ventilation is not recommended. Please appreciate the fact that in this question in the exam, because the patient was conscious and alert, we used non-invasive ventilation. Otherwise, if the person was comatose, we would not have gone for non-invasive ventilation because airways are not protected. So you always need to ask yourself, can patient clear his airways? Can he cough out his secretions? So if person can't clear airways, if he can't even cough, like a COVID-19 pneumonia patient, he's so tired of coughing and breathing so hard that person can't take care of it, so removing out his lung secretions, then the person will definitely deteriorate. So any CNS event if present in a person, or if a person is having coma, you cannot put him on non-invasive ventilation. Then if person has MI, unstable angina, because these are coronary events which can deteriorate very fast. Local causes can be like if somebody has had face surgery or there is a upper airway obstruction, then we should not go in for non-invasive ventilation. I have discussed non-invasive ventilation separately in the mechanical ventilation strategy. You can go to the emergency medicine section of the app and you can listen to the mechanical ventilation component where I have talked about it. Non-invasive ventilation. The learning point for this question is non-invasive ventilation is the preferred management for acute exacerbation of COPD. However, this requires the person to be cooperative, conscious, and alert. If the person is very drowsy, if he cannot take care of his airways, then do not go for non-invasive ventilation. Then you have to obviously electively intubate or rapid sequence intubation, and the positive pressure ventilation is to be done in the patient. Answer to question number 25 is choice number D. Coming to the next question, he talks about multiple sclerosis where the defect occurs. Well, you know it's a demyelinating disorder. So this is relatively an easy one. It's a Guillain-Barré syndrome, multiple sclerosis. They're all demyelinating disorders. Difference is that in Guillain-Barré syndrome, the demyelination occurs of the peripheral nervous system. And here the antibodies and the cytokines which are produced here, they cross the blood-brain barrier. In fact, multiple sclerosis, there is a damage to the blood-brain barrier, and it's only the CNS component that is primarily involved. So it's the myelin sheath which is mainly affected. Multiple sclerosis may even cause spinal cord involvement, that is neuromyelitis optica, because transverse myelitis component can occur. But per se in multiple sclerosis, predominant involvement is of the CNS, and in Guillain-Barré syndrome, the mainly involvement is the peripheral nervous system. The answer to question number 26 is beta. The demyelination is the highlight of this disorder, and that is why there is a conduction delay, and that's why the manifestations will occur in the patient. A related image that I can highlight is Dawson fingers. You can notice the whiteness in the periventricular area. You can see the ventricles here, and then you can see this area which look like finger projections. In fact, I'll use a white pen to highlight these finger-like projections in periventricular area. And the technical term that is used for it is Dawson fingers. That is a MRI, gadolinium enhanced MRI findings for this patient. The preferred investigational choice of this demyelinating disorder of the predominantly the brain and maybe spinal cord involvement rarely is gadolinium enhanced MRI. What does Dawson finger indicate? So it indicates periventricular demyelination, and then subsequently a repair also. I mean, initially there is a demyelination, then the gliosis component will take over. So he might write the word periventricular, or he might write the word perivenular around the cerebral veins. Demyelination occurring in this patient. The criteria that are useful for diagnosis of this condition are called as McDonald's criteria, revised McDonald's criteria, and the treatment of choice for this condition is beta interferon. You can go in the main app for multiple sclerosis topic. It's always a high yield topic from CNS perspective. I mean, if you ask me what is one topic that I should revise from CNS, always at least 1 month before the exam, then I would suggest you to revise multiple sclerosis. See, Guillain-Barré syndrome is easy. All of you have seen cases and you would be able to answer. So is the case with Parkinsonism. So is the case with Alzheimer's disease. But multiple sclerosis covers a lot of things, because there's a wide range of manifestations there. So I would suggest you to definitely give a quick read at maybe 1.5x to multiple sclerosis, just brushing up the basic facts, and it's always useful. Coming to the next question, we are talking about a 45-year-old male, unknown case of RA. He's on monotherapy for many number of years. The symptoms are controlled, but he's having blurring of vision. So he says, which of the following drug is responsible for this vision impact? You are aware of the fact that in rheumatoid arthritis management, we have to use disease-modifying anti-rheumatoid drugs. I think everybody is clear that non-steroidal anti-inflammatory drugs are not recommended for rheumatoid arthritis anymore. And the antibody useful for diagnosis of this condition is anti-CCP, cyclic citrulline peptide antibody. The drugs that we use mainly are immunomodulators, and one of them is methotrexate. But methotrexate does not have effect on vision. So the drug that this guy is preferably on is hydroxychloroquine. You are aware of the fact that this drug is documented to cause what is called as bull eye maculopathy, which explains the entire profile of this question. Hydroxychloroquine is recommended for mainly female patients with rheumatoid arthritis, especially when they're planning a pregnancy. But we can use it as an add-on drug along with methotrexate. Hydroxychloroquine can be added. The side effect is bullseye maculopathy. So either the person will use the word hazy vision, or they might just say the word blurred vision, or you might just read an alternative term like blind spots being appreciated by the person. So whenever a person with rheumatoid arthritis on hydroxychloroquine is suggesting of, or rather is complaining of these effects, you should discontinue the drug on a priority. Halos around lights, they are usually documented in glaucoma, but then even hydroxychloroquine is documented to cause it. Whenever you read any of these terms that I'm writing before you, like lady of rheumatoid arthritis, she's on hydroxychloroquine and she says, I have become more sensitive to lights. I feel as if the lights is hurting me in my eyes. Or she can see some colored halos around the light, blind spots, hazy vision. Drug should be discontinued immediately and alternative immunomodulator drugs can be used. Answer to 27 is delta. We preferably in rheumatoid arthritis prefer methotrexate, but then as an add-on or in some cases where methotrexate side effects are beyond what a person can tolerate, hydroxychloroquine can be started. I've already highlighted for pregnancy aspect, hydroxychloroquine would be recommended. Methotrexate is obviously teratogenic. The next question is a straightforward one. Which of the following is a rich source of vitamin B12? You are all aware that B12 can't be synthesized by human body, no? So it requires exogenous supply. And the exogenous supply will be obviously from meats. So answer to 28 is C and is discussed even in PSM. The next one was a good one. He mentioned what is the differentiating feature between irritable bowel syndrome, where a person has alternative diarrhea and constipation, tummy pain, which is relieved after going to the washroom, and inflammatory bowel disease. Well, the fecal test that we have as of now for diagnosis of this is called as calprotectin. In fact, I've discussed this in the inflammatory bowel disease lecture as well. You can go through the IBD lecture at a fast pace for a quick revision. The answer to this question is beta. You see, pain in the abdomen can never be a differentiating feature anyway, and neither can be mucus and diarrhea because you can't quantify. No? I mean, you can't quantify pain as mild pain, moderate pain, or severe pain. So, quantification is a problem here, and therefore, calprotectin is the one which is recommended. In fact, in the fecal matter, there are two tests which are available as of now. One is fecal lactoferrin values, and second is fecal calprotectin values. And therefore you can identify the fact that yes, this is inflammatory bowel disease. Lactoferrin is a good test. It will detect intestinal inflammation. I mean, you see, earlier we were doing antibody test, no? Like I was teaching P-ANCA being useful for ulcerative colitis and anti-Saccharomyces cerevisiae antibody for Crohn's disease. I'm teaching in the main app, and here the lactoferrin will tell you regarding presence of intestinal inflammation. When it comes to calprotectin, what does it tell you? It mainly talks about histological inflammation. So there is no inflammation when it comes to irritable bowel syndrome. But in inflammatory bowel disease, obviously there is a evidence of histological inflammation, which you don't need to do a colonoscopy with a biopsy. You see, what is the advantage of teaching you this? There is no need for colonoscopy. If you are having a histological inflammation in IBD, calprotectin in the feces would definitely be elevated. If this is elevated, it also predicts a relapse. Like a person of ulcerative colitis, he had an exam and he was stressed out, and the bloody diarrhea was 10 times per day, 12 times per day. Like every 1 hour is going to washroom, only blood coming. Then relapse of ulcerative colitis can be evaluated with fecal calprotectin levels. So do remember these statements of mine. That is, fecal lactoferrin and fecal calprotectin are tests which help you in identifying that yes, it is inflammatory bowel disease over and above irritable bowel syndrome. Answer to 29 is Bombay. A patient with pulmonary fibrosis comes to the emergency department with arrhythmia. Which antiarrhythmic drug should be avoided in this case? You see, the problem in this patient is lung involvement. Lignocaine, we are all aware, it is useful for treatment of post-myocardial infarction and ventricular tachycardia. Procainamide can be used in ventricular tachycardia and in Wolff-Parkinson-White syndrome. Amiodarone again in VT. So three drugs are where VT is used. Why do you use verapamil? Well, you use it for rate control. What are the arrhythmias where you use it for rate control? I hope you remember atrial fibrillation, atrial flutter, and then also for PSVT. I mean, though in PSVT we prefer adenosine, but then even for rate control we can use PSVT management. Verapamil definitely will help because it will increase AV nodal block. Now you can see the fact that there are three drugs for VT and one for supraventricular tachycardias, and the limiting factor here is pulmonary fibrosis. I mean, there is some kind of lung relation with the four choices here. I mean, we need to remember from pharmacology which of the following four drugs is related to development of lung involvement. Well, the correct answer for this one is amiodarone. Amiodarone has been documented to cause both acute and chronic lung presentation. The chronic lung presentation, even the pharmacologist would have taught you this iodine-rich compound can contribute in the long run to pulmonary fibrosis. What I am teaching you is that amiodarone, after administration, this iodine-rich compound can contribute to even lung toxicity immediately within few hours of administration. So you can even be having a acute presentation of amiodarone related damage. So what does amiodarone cause on immediate basis? It can cause interstitial pneumonitis. Looks very surprising, but is true. Amiodarone can cause a development of drug-induced interstitial pneumonitis, because normally nowadays interstitial pneumonitis that we are seeing is COVID-19. But interstitial pneumonitis has been documented even with amiodarone, and this can deteriorate even further. Shocking but true. ARDS. I mean, it will look very surprising when you read this for first time that amiodarone administration can cause ARDS. Yes, it has been documented to cause this. So chronic presentation is fine, but even the acute presentation of interstitial pneumonitis and ARDS is to be taken into consideration. And because this drug has these lung side effects, I'll be wary in using this in the patient. I mean, it was just a twisted question from pharmacology. He, instead of saying that a person is having, or instead of just saying which of the following antiarrhythmic drugs will be having side effects related to lungs, he has chosen to ask regarding amiodarone. This question would have become tricky had he included adenosine. You would have noticed that because adenosine causes bronchospasm. No? If you have ever pushed adenosine into a patient, 6 milligrams for PSVT, the moment you push adenosine, person will say, sir, I feel so suffocated. I mean, you need to warn the patient in advance that when I will push the drug, you will get a feeling in your lungs as if, airways are closing, and it will pass away in 30 seconds to 1 minute. So bronchospasm is a lung side effect of adenosine, and he was smart enough not to include that in the options. Basically, the learning take home point from this question is that there are two drugs beginning with alphabet A that are antiarrhythmic drugs which are gonna have lung side effects. What are those? Adenosine and amiodarone. Coming to the next question, we talk about a 32-year-old man with restless leg syndrome who comes to the OPD. What is the appropriate first line treatment? Well, if a person is having iron deficiency anemia, then iron supplementation is to be done. But in this question, there is no mention of any iron deficiency in a person. So, if iron deficiency was documented, iron supplementation would have been the first line answer for this question. Otherwise, we will go with standard pramipexole. Now, when it comes to restless leg syndrome, they have done a lot of studies on this topic, and when they have evaluated the PET scan of the brain of these patients, they have found some problems with release of dopamine, and these are mainly in the striatal area. So I'll just mention the pathology here. Restless leg syndrome has been documented that in the striatal area of the brain, the release of dopamine is defective. It's a presynaptic dopamine release malfunction. The release of dopamine has been found to be relatively lesser. So please remember that this is the fundamental defect which has been documented, and therefore pramipexole, because it activates the dopaminergic receptor, so it will make up for this deficiency. I mean, this is just incidental. They restless leg syndrome, when they started evaluating, initially the textbook used to say cause is not known. Incidence is more common in anemic patients. That is what I used to read. But now he says the PET scan of these persons show decreased release of dopamine in the striatal area, and once you stimulate the D2 receptors, Then pramipexole does this job mainly. It's a dopaminergic receptor agonist, so the manifestations of dopamine deficiency in the striatal area will become lesser, and that produces a clinical improvement in the person. Gabapentin is mainly used for neuropathy components, so I would like to rule out at least two options here. Vitamin B12, which is for subacute combined demyelination, where there's a loss of proprioception, is where we give B12. And gabapentin is mainly used in diabetic neuropathy or sciatica. So two options are ruled out between A and C, and most guys were confused between A and C only because he has written first line treatment. Now, obviously, we can fight it out now, but I think that why C is not the answer is because the textbook says that iron supplementation is first line in iron deficient patients. Here, he has not given the scenario of iron deficiency. On that, the counterpoint of a lot of my students in a live face-to-face class was that, doc, in India, everybody is anemic. So I agree to the fact that I would like to rate this as a question which was either having issues with recall, that maybe he had mentioned something related to absence of pallor in the person, or maybe he had given some hemoglobin value. So one is a wrong recall or a defective recall. Second is that he wanted to create controversy in our mind and whatever he thinks is the right answer. So according to my wisdom, I think that though in the textbook iron deficiency management is given first, not everybody is iron deficient, and there is no evidence of iron deficiency given in the question. So my suggestion for you to answer this as would be pramipexole. Answer to 31 is alpha. 32 says aquaporin. You are all aware aquaporin is the V2 receptor in the collecting ducts, and if there's a aquaporin deficiency, then the problem would be that antidiuretic hormone can't act, and if antidiuretic hormone will not act, it will cause nephrogenic diabetes insipidus in a patient. Liddle syndrome is overactivity of epithelial sodium channel, and the main presentation of that is hypertension along with metabolic alkalosis. Bartter syndrome is a defect in the thick ascending limb of loop of Henle that will cause mainly salt wasting. So the defect is definitely not in the collecting duct. In Gentleman syndrome, the defect is in the distal convoluted tubule and again causes mainly features of salt wasting. So the bottom line is that all the other defects would be related to areas which are not related to aquaporin site. I mean V2 receptor deficient, V2 receptor malfunction will contribute to NDI, nephrogenic diabetes insipidus, that is treated with thiazide diuretics. So answer to 32 is alpha. The next question says a person was brought to the emergency department and was diagnosed as having a supraventricular tachycardia and suddenly became unstable. That is, the BP of this person fell. What is the next line of management? I have explained in my arrhythmias discussion, and I will highlight this again, that whenever you have hemodynamic instability in any arrhythmia, your straightforward answer will be DC shock in the patient. So in this particular case, there is no role of drugs because he is hemodynamically unstable. That is why the answer is DC cardioversion. Where do you use ibutilide? Ibutilide is used for rhythm control. One, we have rate control, and second, we have rhythm control. So for atrial fibrillation and atrial flutter, it is mainly rhythm control. Diltiazem is mainly used for rate control. It can be used for rate control in atrial fibrillation and flutter along with esmolol. And when it comes to intravenous flecainide, you will be using this for management of Wolff-Parkinson-White syndrome. The answer to this question is option number B, a pure hardcore internal medicine MCQ. The concept is in any tachyarrhythmia, if it is an unrecordable blood pressure in a patient, if there's a hemodynamic instability demonstrated in a person, we straight away need to prefer going for a DC shock, and this would be a synchronized DC shock because non-synchronized is given in ventricular fibrillation and for patients of ventricular tachycardia who are pulseless. 34 says C-wave in JVP indicates, you would have read that in physiology also, it's related to the bulge of the tricuspid valve into the atria. I'll draw a quick diagram to make you revise this. Have a look at this one and please be patient. The diagram that I'm drawing here before you shows IVC, isovolumetric contraction. So C-wave is found in IVC. During IVC, no blood comes in the heart and no blood goes out of the heart. So in the diagram, I've shown pressure being generated, which will contribute to slight bulge of the tricuspid and mitral valves in upward direction. Because of the bulge, the vector is pointing upward. You can take this to be representation of the jugular vein. So what's going to happen next is, because the vector is pointing upwards, the column will go slightly upwards. So the reason for the C wave is the bulge of the valve. It's the bulge of the TV. TV would mean tricuspid valve into the lumen of the RA, because we are dealing with right side of the heart now. So bulge of the tricuspid valve into the right atrium during the stage of isovolumetric contraction is the one that indicates the C wave. Answer to 34 is Bombay. 35 says large irregular friable vegetations. The moment you read the word friable, that means they can embolize out, and that's the standard presentation of infective endocarditis. Rheumatic heart disease will be having rather smaller vegetations, and these vegetations are mainly at the lines of closure and not, I mean, the friability part is not there, no? Because they're friable, that is why there is embolization of these vegetations into systemic circulation, and that is the reason why you get so many immediate complications, including splenic abscess, brain abscess. I mean, any organ abscess, including digital gangrene, can occur due to the embolization of these vegetations into distal circulation. It's like heart is pumping bacteria into systemic circulation. The inferior two are examples of sterile endocarditis and would not be having large irregular friable vegetations. SLE, lower part of the valve, is usually involved in limb and sacs. Non-bacterial thrombotic endocarditis is seen with acute myeloid leukemia, the M3 variety. Even with ovarian cancers and even pancreatic cancers, it's related to malignancy. The bottom line is non-bacterial thrombotic endocarditis is related to malignancies, and A, C, and D are examples of sterile endocarditis. The answer to 35 is Bombay. Coming to 36, this is about a 4-year-old male child who is presenting with muscle weakness. The mother tells that the child has difficulty in climbing stairs and getting up from the floor. So what is he talking about? He's talking about a classical Gower sign. Because if you're sitting cross-legged on the floor and you just stand up suddenly from a sitting position, our hip joint muscles are powerful enough to help us stand. But here there's a definitive Gower sign documented, and then he said on a muscle biopsy there is absence of dystrophin and myofibrils, so the diagnosis will be Duchene's muscular dystrophy. Why it is not Becker's muscular dystrophy? Because Becker's usually presents at and beyond 10 years of age, whereas Duchene's usually presents between 4 to 5 years of age with two problems. One would be waddling gait. When the child will walk, his shoulders will sway from side to side. So one of the reasons why these children are brought to use waddling gait. Second would be recurrent falls in stairs. Like the mother will say that we stay in a multi-story complex. Suppose the lift is not working, and or lift is not being used because of COVID, and children, they keep on playing in the stairs. So this child is going up and down the stairs, and he falls every time. Whereas she says his cousin brother, his elder brother, or his cousin sister, they don't fall. So the mother is worried because the child is actually, she is not aware, but the child is actually having a proximal hip joint weakness. Myotonic dystrophy mainly has distal weakness. So I'm ruling out option number C because myotonic can have a presentation in infantile age group only. And when it comes to limb girdle muscular dystrophy, this could be presenting in adolescent age group also. I agree that age is not a criteria for diagnosis, but when it comes to Duchene's versus Becker's versus myopathies that I mentioned before, your muscular dystrophies, and you must take into consideration the age component. The answer to this question is definitely beta. And remember my words, dystrophy means progressive weakness. Myopathy is standard presentation. Coming to the next question, he talks about a patient having a pH of 7, which is less than normal. So it is an acidic pH. PCO2 is 30. PCO2 of 30 cannot explain the acidosis component. But if bicarbonate is less, normal bicarbonate, as you are aware, is 22 to 26 millicoulombs. So I can say the fact that it is mainly low bicarbonate that can explain the acidic pH of this person. So the primary problem of this particular person would be a metabolic process. This metabolic process would contribute to metabolic acidosis. Now, why low PCO2? Metabolic acidosis always causes hyperventilation, and this hyperventilation contributes to carbon dioxide washout from the body of this person, and secondary to the carbon dioxide washout, the end result in this person would be a decrease in the value of CO2 than normal. So what is the primary process? The primary process of this person is metabolic acidosis. The answer to this question is C. You can solve it another way. If you look at the direction of arrows, you see pH is less than normal, PCO2 is less than normal, bicarbonate is less than normal. I have explained this in the ABG section. I would request you to listen to the ABG section again and maybe only 1 or 1.2x, because that involves a couple of concepts also. So ABG both lectures, it will just take 1.5 hours of your time, but believe me, that will increase your strike rate in the exam. So if the direction of arrows, is same for pH, PCO2 and bicarbonate, it is always less, less, less. It indicates metabolic acidosis. If all the arrows are going up, then it is metabolic alkalosis. So direction of arrows of pH, PCO2 and bicarbonate also help. If you can remember the table, great. Otherwise, just try to solve it the logical way. I mean, acidotic pH can be explained either by elevated PCO2 or by low bicarbonate. Here PCO2 is less than normal, so cannot be a respiratory process, because for respiratory acidosis to occur, PCO2 should be more than 45. But in this case, it is low bicarbonate that will explain the metabolic acidosis component of this person. Let us see that is it compensation or is it mixed. To differentiate compensated versus mixed, this is optional for you. What I'm saying now, you should calculate expected PCO2 value. Expected PCO2 value is bicarbonate plus 15. In this question, you can see that PCO2 is 30, but actually it should be 25. Just listen to this formula again. Expected PCO2 value in a metabolic acidosis case can tell you in differentiating between whether this is compensation process or is it a mixed disorder. If in this MCQ the PCO2 was 25, then it would have been compensation. But because it is 30, it means compensation is not working. There must be separate abnormal process. So I want to tell you that this is a question of a mixed disorder. I repeat the facts once again. How do you differentiate between mixed disorder versus compensation? Just apply this formula. Expected PCO2 is bicarbonate plus 15. If this formula is satisfied, if the value is coming as 25 or lesser, that means that compensation is working. But if the PCO2 value is not 25, it's rather more than normal, this means the fact that this is an example of a mixed disorder. So what is the final diagnosis of this ABG report? The final diagnosis of this report is metabolic acidosis with respiratory acidosis. Please remember, I agree to the fact that the compensation of respiratory alkalosis is working, but it is not working adequately because there's a separate, maybe this person is having diaphragmatic paralysis that is contributing to respiratory acidosis component. So this report that I've shown before you, because it does not follow this formula that I mentioned, that is why it is mixed disorder. So it is advisable that in all questions, this was an easy question. He simply asked metabolic acidosis, but he can make it difficult, especially names. So my request to you is go through the ABG questions and always in questions try to see that expected PCO2 value is being obtained or not, because if it is being obtained, it means it is compensation process successfully working. Mark my words there. If the mathematical formula is satisfied, that means that the successful compensation is occurring. Otherwise, there must be a pathology, a second pathology going on in the person. Like in this chap, it could be maybe hypokalemia contributing to diaphragmatic paralysis. That can explain the respiratory acidosis component of this person. So this is actually a mixed disorder. Coming to the last question, he says, in which clinical scenario after giving folic acid, neuropathic features will start worsening? So the bottom line is, and this is taught right from first year in medical school, that if a person is having B12 deficiency, he will be having macrocytic anemia, folic acid deficiency, also macrocytic anemia. Now suppose somebody is having B12 deficiency and you start giving folic acid. Let us see what happens. When you will provide folic acid to the patient, the RBCs of this person will definitely start using this folic acid for DNA synthesis. And when they will do DNA synthesis, they will require B12 also. B12 is already low. If to somebody with B12 deficiency, you are giving something that is not the primary requirement of this person. The primary requirement is provide B12. No, if B12 is deficient, provide B12. If you provide folic acid, what will folic acid do? It will help in RBCs producing DNA. And when DNA synthesis will occur, it will consume the already low B12 of the patient. I repeat the statement once again. The B12 of this person is already low and you are misusing it for DNA synthesis for red blood cells. This will consume the already low vitamin B12. This will decrease, and therefore the neurological features of subacute combined demyelination might actually be unmasked. In subacute combined demyelination, it is mainly the damage to the dorsal column, due to which the joint and position sense and proprioception sense is lost in the person. So proprioception loss in the person can actually manifest it. The learning point for us is that in every case of B12 deficiency, primary requirement is to give B12 and folic acid, but if you give only folic acid, then it will consume the residual B12 also by utilizing and diverting it for RBCs producing normal RBCs, because you have macrocytic anemia here. No, so there's a diversion towards the RBC side, and the neurological component gets deteriorated. The answer to this question would be given as option number B. So these are the aspects, guys, that I want you to understand. I personally feel that this was a average to slightly hard paper. Uh, some aspects are very simple. I mean, some questions are like, waiting for you to grab onto the correct answer. Some of them are having dicey choices, but my personal opinion is that if you go through your notes at least twice, upgraded notes means that you have done questions in the app and simultaneously use the order. I am definitely sure that you will be able to upgrade your strike rates. Thank you so much, guys, for keeping the focus on. I know that I've taken up a bit of your time, but I hope it will be productive for you. My best wishes for your exam. Thank you.